let me stop taking bite.
Cool. Well, good morning, everybody. Thank you all for being here. It's a small group, but you know, I think it'll be a mighty group. Yes, absolutely. I know some people are working on the pre-survey, so I'll let you kind of finish that up. But while you're doing that, I think we could potentially hand out the participant toolkit. Oh, there you have them. Look at that. Sweet. Yeah, I think so. So since it's such a small group, we probably can go around and do some small introductions. But welcome everybody to our advanced EM workshop on our JEDI simulation toolkit. We hope that you'll be able to, you know, learn something new and be able to take it back to your institution and do some cool simulations. We all don't have disclosures except for Samreen. She is a co-founder of this company that does some training for simulations, and we do use some of her materials in this presentation. This is our itinerary today, which does not apply since we're being flexible, but general flow. So with that being said, we are going to let all of our faculty introduce themselves as we kind of go through the presentation, but I'll kind of start. My name's Will. I'm one of the fourth year ER residents, be graduating in a month. I'm currently at Denver Health. And I had the pleasure and honor to work with this great group of people. And yeah, with that, I'll go ahead and pass the mic off to Dr. Romo. Thanks.
Thank you, Will. And, you know, we're going to praise Will all day, but he's not only working with us, he's really led this team, and he's amazing. We wouldn't be here in this shape without Will. So we wanted to, you know, start with just some community norms. How many of you use community norms right now for your simulation groups? Amazing. I put mine down. I mean, we have some norms, but we haven't been as formal as this, but I feel like for a lot of the DEI work that we do, or whatever you can call it at your institution right now, using community norms is a great grounding tool, right? We'll talk a lot about psychological safety today, and this is a great way of creating an atmosphere that allows for a new and more communal psychological safety. And so these are the ones that we're proposing for today, that we use I statements, share airtime, lean into curiosity, distinguish intent from impact, assume good intent while remaining open to feedback, respect confidentiality, and allow space for uncertainty and growth. Also love to introduce kind of the norms of oops and ouch, right? So if you hear something, or if, you know, let me start with, if you say something that you're like, as soon as it comes out of your mouth, you're like, that's not how I wanted this to sound, you can always say oops and kind of reframe. Or if something, you know, kind of activates your ears and you go, ouch, right? And just, you don't have to really explain, but we can pause and kind of share what we're feeling, or just, you know, allow for kind of a redo. Any other norms that folks would want to use this morning? Awesome. So before we move on to the next part, we wanted to go around, introduce ourselves, let you introduce each other as well. And we were hoping that we could maybe just share one word, or, you know, we have the time and space, a little bit more about how you're showing up today. So I'll start. My name's Ernesto Romo. I use he, him pronouns. I'm at Washington University in St. Louis. And I'm showing up super energized, would be my word. And I've just had 3 sips of my coffee, so. Which is decaf.
My name is Denise Marte. I am faculty at Brown in Providence, Rhode Island. And I use she, her pronouns, and I'm hungry to learn today.
I'm Priyanka Kandal. I am faculty at UT San Antonio, Texas. I use she, her pronouns as well. I feel great. I'm 4 months postpartum, and I got the first 7 hours straight of sleep last night.
It's real.
I'm
Smriti. I also use she, her pronouns. I am some faculty at the Humanities Medical Center in New York City. I also work at a couple of other hospitals in Brooklyn, so everyone, all the frequent flyers know me. I am showing up hopeful today. I've had a little bit of a, burnt out a little bit from academics and had fine when I start again. Looking forward to being here.
I am Samarine Bora, and I am a faculty at Yale in simulation. And I was going to say hopeful as well. I am hopeful. I'm glad that you all are here for this workshop. I'm glad that I got to work with this group of really incredible people.
Oh, me? Okay, all right. I wasn't sure which way we were going. I'm Jackie Bourgains. I'm faculty at University of Colorado, and as part of Denver Health faculty, health residency faculty. And I'm trained in health equity and principles of diversity, equity, and inclusion, and spend my time in a role for GME, in that role, formerly known as the director. I feel like I need a Prince symbol. So.
The faculty formerly
Known as, yes.
Hi guys, I'm Renee King. I am at Denver Health, which is across town from the university, but we share residence. I'm faculty there. I'm director of engagement and recruitment, part of faculty development at my shop. And I'm feeling, I use she, her pronouns. And I've had a good week. It's been nice to see people that I see maybe once a year and see all the really cool stuff people are working on, the good work that they do, and all the positivity that has been coming out. And it's been really interesting. It's been a great conference. So happy to see everybody, and hopefully it's not a full year before I see people again, but it might be.
Everybody again, Will, he, him pronouns. I am feeling pretty inspired to be in a room with a lot of people I look up to, so happy to be here.
Rachel Keene, I'm one of the faculty at University of Missouri for the residency of simulation, assistant simulation director, and also the assistant director for the fellowship for simulation that she, her pronouns, and I was sleepy kind of shy, but I'm excited.
I'm Ala Albalati. I'm an APD at KU in Wichita. I'm also assistant director for CarePoint Health. I'm excited to be here. I'm also 4 months postpartum. So it's my first time away from the baby, which is kind of, it's nice in a way that's something different.
Awesome. Well, thank you all for sharing. So nice to get to meet some of you a little bit, share in such exciting times. I should have slept better because my 5 and 3-year-olds still really suck at sleep. But alas, I was not doing that. And so our objectives for today: identify and explain 5 evidence-based principles that underpin practical JEDI-focused simulations in emergency medicine. Apply an evidence-informed toolkit to design and adapt equity-centered simulation cases. Simulated participant selection and training, simulation approach, facilitation, and evaluation strategies, and develop an approach to the sustainability, scalability, and learner impact of the JEDI simulation using equity-aligned metrics and structured feedback. And for the bigger picture of why we're here today, I'm going to pass it on to my colleagues, Will Mundo, and is Cyrus here? No.
No, he's not here. Thanks. So Cyrus is actually a current simulation fellow in California, and he's part of our group, helped put some of these content together. So I just want to give him a shout out. You know, kind of want to set the stage here for like why JEDI simulation matters, and kind of feel like I'm preaching to the choir, but you know, I'm gonna just kind of go for it since it seems like I don't need to convince you all. about this, but ultimately for this specific section, I briefly want to explain why simulation is actually in a unique position to be able to address these JEDI concepts as it pertains to emergency medicine. We will talk a little bit about the current evidence landscape of JEDI simulation, and then kind of talk about some of the gaps, which then propels us to these opportunities are available for us to be able to integrate these challenges into this toolkit. And so, why are equity challenges central to emergency medicine? I think for the most part, everybody can see that we frequently encounter a lot of these challenges in the emergency department. We operate at the intersections of acute clinical care and really the broader and social structural inequities that we see. We care for patients who often face language discordance, or they have limited access to care, structural racism, and really mistrust of the healthcare system. And these challenges, they don't show up just as clinical problems, but they often show up as communication challenges. We see them in our interpersonal dynamics, either with, in a subconscious way or even in a more overt way with some of our colleagues. And, we also function as a healthcare's safety net. And because of this, we frequently encounter these situations where structural inequities become very visible during some of our clinical encounters. And so then the question becomes, how do we teach clinicians and, in this case, residents, our future healthcare leaders, how to navigate these complex communication encounters? And that's really where simulation plays an important role. So are didactics and policies enough to change practice? We know that in its current form, a lot of JEDI education is commonly delivered through lectures. That's kind of the most traditional format. There's a couple of online modules, that sometimes we're forced to take, for lack of better words. And there's sometimes one-time workshops that are available to us. And while these are a good start, and it's what's available out there, they focus a lot on knowledge acquisition rather than being able to apply this practice. And that's kind of where simulation is important, right? Because there's a big difference between knowing and doing. And additionally, simulation allows us to be able to meet learners where they are, rather than assuming, everybody's at the same level, because we know that we are all at different levels when it comes to our comfort level, when it comes to discussing some of these issues. So when we think about the traditional educational model, whether we're talking about lectures, modules, policies, we're really hoping to frame this toolkit in experiential learning. So where we talk about simulation, where we talk about practice and feedback. And that's really where we can transform from the knowing to doing. And so how do simulations challenge the current norm? Like I said, it helps us rehearse for high stakes communication encounters. Whether we're talking about language access failures, racism, or bias in encounters. It allows us to address real-time power dynamics and team response. And ultimately, what it helps us do is that it gives us an opportunity to be able to perform deliberate practice under pressure and then assess for behavior change. And so this is kind of where we go from the experiential learning to really the theoretical components of how we can address these issues. And so I did have this QR code here to kind of ask. I was going to do a survey in terms of what people's current experience is, but I think since we're such a small group, I think we could probably just kind of talk about it. So I'd love to hear if you feel comfortable sharing what your experience has been with JEDI simulation in your existing institutions.
I would say we have zero. None. I think it's something that is actually very difficult right now in Texas, as you probably all know. We had to reframe all of our DEI initiatives as educational opportunity, and even that has been very difficult. I teach an undergraduate medical education course about a bunch of things
Are you all doing, like, I'm guessing y'all are doing like regular simulation, like for like medical competencies and stuff, but, okay.
Like in the residency program, we do a monthly simulation day.
Nice.
Or at least like a large group. Sometimes it's not classic sim. But we do a fair amount of simulation and we have a sim director. So we have to incorporate some of these.
So I'm a social EM faculty. I'm actually not sim trained at all. And when I was at my current institution, we don't have any social EM focused sim. When I went to residency, I was involved in planning a few sim sessions, and it was really interesting. I think the feedback was also really interesting because it was sort of, we assumed we were making very obvious the types of issues we wanted to like dive in on, and it somehow got political for some people. So, you know, trying to, before incorporating it into a new institution, trying to refocus, how do we give it the same level of respect and like evidence base as, you know, talking about a fractured asthma patient. So that's really one of the big things.
Yeah, nice. Thank you for sharing that.
In New York Presbyterian.
Mm.
I can also share.
Yeah, please.
We have like a pretty
No, I didn't share, but I think we're code of the city talked about the Missouri, so we don't really have a whole lot.
In New York, it's a little interesting. I also had a fellow facultation of DEI, and we had to just, we're going to keep the FTE, but just take the higher title. And we also we have a very robust SIM curriculum, and I was in charge of the social and DEI aspect of it. So we actually had it scheduled out for the residents. The residents and the faculty enjoyed it, but then the administration ended up kind of shutting it down. So I also had to figure out how to frame it.
Yeah, thank you for sharing. So kind of just to kind of do some reflect on what you are saying, it sounds like maybe definitely some institutional political kind of constraints. It seems like is a very common issue. Maybe, you know, some resource limitations as well. You know, if you don't have that buy-in from leadership, it's kind of hard to, you know, allocate those resources. What about like lack of structured guidance or frameworks? Do you all feel like you have if you wanted to do this in your institution, do you feel like you have some framework that you can use to do this type of work?
I mean, in a very basic sense,
Okay.
like one could look up a template of like, you know, how to create a sim case.
Yeah.
How much time do you devote to the case
For
itself?
sure.
What sorts of prompts do you want to?
Yeah.
That at the very basic level,
Okay.
yes. But again, moving past like, oh, how do we feel about this patient population to a place of what is the evidence base, and like what is helpful to patients in the emergency department, and what should you as a provider be competent in doing for patients who have more than just medical needs. I think that's the hard part of
Sure.
finding what's that sweet spot.
Absolutely. Yeah, and I think it's hard, right, especially if you don't have the faculty experience and, you know, expertise. So luckily today, you're going to leave with a framework that you can take back to your institution. So thank you for being here. So really quick, just to discuss the current state of JEDI, and I just want to say that I'm using this term here because, you know, it's, you know, a safe space to talk about this, but, you know, you can replace those 4 letters with whatever, you know, whatever constraints in which you're operating. But, you know, I think one question that you're probably asking yourself is like, if simulation is so well for practicing these challenges, you know, what does the current evidence kind of look like? And so the first thing I want to discuss was the scoping review by Daya and colleagues in 2023. And it pretty much looked at how simulation is currently being used for equity-related education. And what they found is that it's actually quite effective for teaching not only procedural skills, but teaching communication skills as well. But it often remains underused for explicitly being able to address things like bias mitigation, culturally responsive communication, and structural inequities in care. Another issue right now is in the literature is the lack of standardization. And so, for example, Nadir and colleagues, they did this qualitative study, and they found that there's a lot of variability in terms of how cases are framed, how standardized patients are prepared, how facilitators are approaching debriefing. And so this inconsistency does introduce several risks, mainly that poorly designed scenarios can sometimes unintentionally reinforce stereotypes. It can cause learner discomfort, it can threaten psychological safety, and a lot of times I feel like I've seen this a lot, it can lead to tokenism and implementation of equity contexts. And so from this, at the same time, while there has been, this work out there showing some of these limitations, we do have some work by, some of the people in this room, including myself, Dr. Ward Gaines, Samreen, where showing that our equity-based simulations can actually improve learner confidence in navigating these difficult conversations, specifically around bias, interpreter use, and structural determinants of health. Also, the other thing I wanted to discuss too is that while there has been a lot of literature showing that there's this could be effective to teaching learners these advanced communication skills, there's very limited frameworks and guidelines besides what Dr. Vora has published in the literature to how to do this type of work. And really that's kind of where we want to take this to the next level in terms of being able to provide that framework. But ultimately, as we look at the overarching evidence that's on there, everything's like predominantly single site, very small sample sizes. We're talking anywhere between like 20 to 50 people max. It's very heavily reliant on self-reported outcomes. There's little to no behavioral patient level measures. It's all like self-confidence reporting. And there's also like inconsistent attention to psychological safety. And because of this, it shows that there is very limited guidance for case framing, topic selection, standardized patient or participant recruitment and training, and facilitation and debriefing. I will say that I just covered a very small snippet of the literature that's out there, so this isn't meant to be fully comprehensive of what's out there. And we put these slides together several months ago, but this is kind of a glimpse as to like what the current landscape is kind of looking like.
Can I add one piece, just because of what you said about the evidence base? I feel like that's why this is so important, right? What Will you just said. One of the studies that you had on the last page was specifically getting at those behavioral and translational outcomes. So this one that Vibert Damon and I was looking at actual outcomes that the hospital cared about that was tied to DEI-based simulations. So it was actually anti-racism simulations and then looking at de-escalation, time escalation events in the unit that we trained over 300 nurses. So really simulation can get at behavior change, and I think that's what all your slides are really getting at that, I think is the important piece. So to your point about how do you base it in the evidence the same way we base other simulations that we use, right? Training into inserting a central line. So what's the outcome? Decrease infections by central line. So I feel like using this toolkit and what we're presenting today to move from thinking about JEDI simulations in the same way. What are the outcomes we're impacting so that our hospitals care, and so we can change our language. So now I've pivoted to using quality improvement language because that's exactly what it was. The SIMs we did, decreasing the escalation events, decreasing the amount of time security has to come, improving their patient experience scores in the entire unit, language that they are very familiar with and care a lot about. But just tying it to the two things.
Yep, exactly. So ultimately, there isn't like a widely adopted toolkit. There are a couple of works out there that address certain sections of what designing a simulation, but there isn't like a comprehensive toolkit. And that's kind of where we're here, right? And this is the reason that we need this. It helps us to adapt these principles without diluting, JEDI concepts. It allows us to have sustainability within curricula. It allows us to have institutional buy-in, and shared language, kind of like what Dr. Vora was mentioning. It will allow us to have fidelity to equity-centered design. It can help us have psychological safety for learners and for our SPs. And also it will allow us to be more consistent with how we're doing things. And so ultimately what we hope is that this toolkit will be able to create a scaffolding for you as you go back to your institutions, but at the same time give you a little bit of flexibility to be able to address, the specific relevant issues that you may be dealing with within your institution. Because I'm sure that things that we're dealing with at Denver can look completely different than what's going on in New York, and so ultimately, we know that equity challenges are core competencies in emergency medicine. Simulation is very uniquely suited to be able to practice equity-related clinical and interpersonal skills, and using this an evidence-informed toolkit can hopefully help us support safe, scalable, and sustainable implementation of equity-focused simulation. So with that, I'm going to go ahead and pass it to my colleague, Dr. Olulati.
All right. Can you guys hear me okay? All right. So we're going to go ahead and discuss the theory behind this toolkit. We did not just, sit down and we're like, hey, you might have an experience in DI simulation. You may or may not have an experience. You look like someone who could have an experience, and just draw a bunch of errors and boxes and put it together. We did not do that. We actually structured this toolkit based on 5 pillars from the simulation and the medical education literature. These are the 5 pillars that we base our toolkit off. The first one is a structural competency, which is our content lens. A lot of healthcare inequities are not because one person saying the wrong thing or being the bad guy. Sometimes it feels like if this physician could just try a little bit harder, be a little bit more sensitive, or just become a perfect human being overnight. That's not going to happen. I wish it can, but it can't. Many of these issues are actually institutional, structural, interpreter delays, transportation barriers, insurance barriers, institutional policies. So when you teach your residents or your learners about this topic, it's important to include these institutional barriers, not just make one learner being the bad guy. Second is the experiential learning. We all know this. We're all simulationists. We all know this. We all know that simulation actually works. You can attend a lecture about difficult conversation and walk out saying, oh, wow, that was powerful. And then 2 weeks later, someone said the wrong thing in the ED, and you'd be like, I wonder how should I respond to that. So simulation, as you know, it creates a place for people to practice real life events when the stakes are not high, when it's not a real patient. Because reading about, difficult conversation is like reading about swimming, for example. Like, you eventually have to get into the pool to learn. You're not going to learn how to swim by just reading about swimming. The third pillar is psychological safety and pre-briefing. This is especially important when it comes to JEDI simulations. These conversations can get very overwhelming. We're talking about discrimination, biases, power dynamics, hierarchy. If learners shut down, they're not going to be open to learn, right? You don't want your learners to feel like they're walking into an HR meeting accidentally. Like, you don't want them to feel that way. So pre-briefing matters, like setting expectations, unpacking emotions, normalizing discomfort, and creating safe space for learning. Fourth thing is debriefing and reflective practice. This is where the actual learning happens. And let's be honest, we've all been in bad debriefs, right? We've all been in a debrief that, oh, you guys have done a great job. Let's just give you a round of applause. And you walk, learn nothing, basically. Or how did that go? And you'd be like, I don't know. Good, I guess. So a good debriefs help learner unpack assumptions, emotions, reactions, communication choices, and structural barriers. This is especially important in equity-based simulations, where emotions can run high. And last but not least is representations and authenticity. This is our fidelity lens. If you're using standardized patients, authenticity matters. We want realism. We don't want stereotypes. We don't want exaggerated accents. We don't want caricatures. We don't want to make this patient's, their entire personality is their identity. That's not going to help anyone. So it's very important to make it as realistic as possible while avoiding exaggerated behaviors or exaggerated reactions. Especially, we'll talk about this a little bit later, but especially when you train your SPs, you want them to avoid exaggerated reactions, just normal reactions. All right, I've talked about the 5 pillars. I'm just gonna put them into action to see what do these mean in a scenario. So let's, for example, take a case for someone who has acute stroke and there is a language barrier, they're non-English preferring language. So when we talk about structural competency in this case, we're going to probably address the interpreter system limitations. You may have readily available interpreters, you may not have readily available interpreters, such as my institution. You don't want to frame this scenario as an individual failure because they did not know how to call the interpreter, because in real life, your interpreter might be like 45 minutes late, and in acute stroke, that's not going to help anyone. You want to highlight the system level factors during that. You want to include institutional policies if there is any, if you don't have any available interpreter. The next thing is experiential learning. In this case, it's important to give them realistic time frame. Don't speed up the case, don't slow it down, just give them a realistic time frame. Let them feel the pressure of like not finding an interpreter, and allow learners to experience the tension of their clinical decisions. And then psychological safety. Pre-briefing really is really important in this case. Don't surprise your learners with an emotionally charged case. And normalize discomfort, normalize uncertainty. Emphasize that this is a learning environment, this is not a judgmental environment. And then debriefing. For this case, we could use advocacy inquiry discussion in which we could explore their assumption and reactions. Why did they say what they said? Sometimes the people say a thing and they don't think about it, and they don't think that might be actually harmful to the patient. And do not lecture them during the debrief. This debrief is for them. They need to unpack. And authenticity. Train your standardized patients, and we'll touch more about it later on, and avoid exaggerated stereotypes. And don't portray language barriers as an incompetence. If I get a stroke in China, I don't speak Chinese, I'm not an incompetent person, it's just because I don't speak the language. All right, so let's go ahead and introduce the kit itself. So the kit has five components. First is topic selection and case framing. This is where you decide what are you actually going to train your learners on. Is this a real problem at your institution? What behavior we're trying to change? Second is standardized patients preparation and recruitment. We don't want to just get someone, yeah, you can play the standardized patients in this case. That's not going to serve anyone well. You need to prepare them, you need to set their boundaries, you need to make sure that they're consistent with every group of learners, and you need to ensure their psychological safety the same way you're ensuring it for your learners. Third is simulation design and delivery. This is where you decide what modality are we using, what structure are we using, what fidelity, what are our learning objectives. And fourth is facilitation and debriefing. You want to address the emotional reactions. Some learners might have defensiveness, so you want to address that. You want to be comfortable in silence, because sometimes you'll end up with silence, and you want to be comfortable with conflict. And last but not least, implementation and evaluation. This is where you sustain your program. This is where you scale it, as Samreen said, this is where you tie it to your institutional goals. And the reason we structure this toolkit this way is because every stage represents an opportunity for excellence, and they're all connected. If one stage falls, you might have the perfect case, but it's going to go sideways. I'm going to let each group then talk about certain parts. We're going to go in a little bit in depth in certain part of the toolkit, and then we're going to have the opportunity to practice this toolkit as small groups.
So I think I've already introduced myself, and you guys can hear me okay, right? Yeah. And I think earlier I didn't, my pronouns, she, her pronouns. And another thing, I'm feeling full. I don't think I also explained how I felt today. And full because someone shared a meal with me. I was very hungry. But full because I've had some family losses, and I got an opportunity to still see family and just love, and then to come straight from there to this group is just amazing, because again, just it seems like it's filling my cup with more continued love and excitement in trying to do this. So my section to talk about is case framing and topic selection.
And so this is one of the most important things, right? Like, how do we choose what to do? I think someone mentioned earlier, right? You just pick something that seems cool. It seems the thing to do. And so we definitely want to avoid just picking a social topic because it seems cool and a thing to do. And so what you want to do is, and definitely when you do that, poor case selection can go really bad. It'll end up with tokenization, as you said, over simplification of the issue, and even defensive reactions from the learners. And so the goal is really working towards behavior skill development in the clinical context. So you're really looking for ability to find behavioral skills and what they need to do to improve in those areas. When you do that, it keeps the cases authentic, educationally meaningful, and relevant locally to what's there. Next, in looking at that is you want to help you do that, you want to anchor the topics on health disparities. By doing that, then again, we pick a health disparity, and then you can go from there as far as anchoring the rest of the case on that. For example, in cardiovascular disease, there are outcomes that differ across racial and socioeconomic status, and so you can use that. You can also use asthma, for example, that depending on environmental exposures or housing situations, things like that, that they have the different outcomes. A good overview of health disparities, or I think the 2023 is a good published paper that will help you just kind of recap on health disparities. Another thing that will help it is to make it important to your institution. When it reflects the local patterns of disparity there, then it's relevant to your institution and your institution cares. Why are we doing these SIMs? Because this is important for our learners here where they practice it. And some sources of where to find that, again, is quality improvement in your area, quality improvement reviews, and coming to your leadership saying, this is an issue here, and we can address this in simulation. Patient advocacy cases, that's a place where you can definitely find where there's reoccurring challenges, and again, which will bring a lot of emphasis and importance to doing these particular simulation cases. And just reviewing over the data in your area. So if you have a high prevalence of non-English speaking patients, that's a good time to do simulations that might bring up and address interpreter use. So. And just because we're a small group here right now, we'll get into it a little bit more, but can anyone, or start thinking now of things in your institution that might be an issue? Okay. Now, it definitely, authenticity is so essential. I love using real cases. When you use real case, you just can't go wrong. It's very authentic. But you want to make sure you don't drift into stereotyping or caricatures, and you want to definitely value the patient experience and be faithful to that. What I find when real cases are not available, I can still use the real events or certain events around it, and then I use my community and local clinicians to help me make sure on the authenticity of the case. And so we'll do like a modified Delphi, and I'll send it around first view, and then we'll get votes on it, and then we'll bring it back, then we'll send it around again, and then we'll keep, and definitely like making sure that we have community input. Now,
the cases have to align with competencies. So again, like I said, it's not just choosing a cool topic, but making sure that our cases align with competencies. The AAMC competencies on justice, equity, diversity, inclusion is a good place to start. And some of those examples is bias recognition, communication, structural barriers to care. And so when we use those competencies, you're able to focus on a behavior a behavioral skill that you can observe and measurable learning objective. All the learners will be able to demonstrate those competencies. So now when we look at that, here's what that framework looks like. You can choose a clinical condition. Then you want to look at that condition through a health disparity lens. Relate that to your local context, what's there locally for you. Make sure you're targeting the learner behavior so that we have that definable, observable skill and competency that you're going to be looking for. And then making sure as you design the case, you think about authenticity. So we go into a case design matrix. And so again, we'll take a clinical condition and let's take something for like sepsis up here, for example, right? And then the disparity is language discordance, right? In our shop, we have a large Spanish-speaking population, and there are interpreter delays during the daytime. And so then the targeted behaviors, we could stress communication clarity, working with interpreters, which we have, closed loop communication, right? And so then we were able to do that knowing that some of the risks and things that we needed to avoid was making sure that we were not stereotyping patients, and I think Alice spoke of it earlier, right? Just because they don't speak the language does not mean that they are confused or anything of that nature. And so making sure that we kind of watch that. Another one we've done is behavioral health crisis, right? And so again, the disparity, right, is the stigmatizing language and the bias towards those patients. And that's something we have from EMS, usually in different labels and contexts, and that's what happens with our great Denver Health medics. And so again, that's targeting what we have going on locally and why we needed to improve on that. And then those real-time or response to the language, how do you actually do that, and really having them do that in a stressful environment. And so again, thinking about those potential risks and trying to mitigate those risks as they happen, okay? So I'm excited we'll get a chance to do that later in the small group, but right now I will turn it over to Sue.
All right, so we'll hop into this piece. It was really awesome hearing my colleagues kind of talk on these other pieces. The one note, as I talk about simulated participants, I'll say that we put this in because I think a really common way to do JEDI simulations is using standardized patients or simulated participants or a human, a physical human, or now AI human, to do these simulations, because a lot of the skills you're often practicing are these human skills, right? The communication. But I will say that thinking about, and listening to you, Dr. Orgains, just thinking about, as we're thinking about JEDI sims, just broadening the spectrum. I know we're talking about specifically simulations that maybe you're focusing your objectives just on this, but thinking about how can you embed, using some of the strategies you talked about when you're thinking about those disparities, how can you embed outcomes throughout your other simulations that you're doing, right? You think about maternal mortality, Black maternal mortality. There's a Joint Commission requirement to do simulations to address maternal mortality, to do simulations around postpartum hemorrhage or whatever those cases are, right? Or eclampsia or preeclampsia. And so you can embed a objective there, as long as you're preparing your facilitators, and we're going to go into that in our toolkit, to be able to debrief that objective. But thinking about how do we use that language and how do we harness that? I'm particularly saying all of that because it ties to us saying, hey, our organizations are saying, we can't do this, we've been shut down. So how can you use that? And so using SPs is the focus that I'm going to go into. So when we think about SPs, even just thinking about, before I jump into this, even just thinking, well, maybe I'll start with phase one is recruitment and casting, and being very deliberate about when you're using an SP, what is the objective and why are we using this SP? SPs, or an actor or a person, right, that human that you're using in your simulation, what are the objectives and how are they going to be participating in that simulation? So when we think about Jedi Sims, you can be using and I should stop using, sorry, there's a huge article about not saying using SPs, and I'm still doing it. So utilizing them as, these humans to help us teach and get to the objectives we want to partner with our SPs to do this. So the SP could be the patient, and even when it's the patient, there's still two possibilities. There's this whole, right, you could have the SP is the one that's experiencing a bias or discrimination, or it could be a patient who is the one perpetuating that, right? We think about how our healthcare professionals experience some of this, and so you might be doing simulations around that. It could be, it's not the patient, it's the parent. I've done, our anti-racism simulations was in the pediatric world. So it was the parent at the bedside with a mannequin. So it was a hybrid simulation. It could be, kind of all of those different, either a hybrid sim just by itself, and what's the role? It could be an embedded participant in the simulation, because being very careful about who that person is really important, right? And them knowing, especially if you're SP or you're embedded participant, maybe as a faculty member or as a student, and now you're asking them to play this role where they're they're simulating a bias so that you can then have the simulation and debrief it. Being very deliberate and thoughtful about that is really important, right? Because that person also then having a disclaimer after, having it be really clear, like, this is not who I am. And also, we've had situations where we did all of that, and then the person who plays that role is still like really uncomfortable, is like, I don't feel comfortable saying those things, and then our whole simulation is falling apart. So when you think about SPs, there's a number of factors you have to consider. So for the first one, recruitment and casting, we talked, I think, a couple times now about authenticity without stereotyping. So having a nuanced portrayal for that character, embedding real lived experiences that are authentic, and then the piece about avoiding re-traumatization. And this can be really challenging, because when you're partnering with an SP to do a simulation, you want to be authentic. So you're potentially you're having an SP, or you're hiring an SP that has intersectional identities with the topic at hand, which then also means they have lived experiences in that space, and the potential for re-traumatization is high. And so being very deliberate in thinking about how is that portrayal, what pieces am I trying to get to? So in recruitment, thinking about representation of the group or the objectives that you're trying to meet and the identities that intersect in that objective. And then when there aren't congruent SPs for an identity potentially that you're doing a JEDI simulation, I've heard a lot of people say, well, I can't find an SP. Say you're doing a simulation around ability and ableism, and disability and ableism. And you're like, well, how am I going to find an SP who's in a wheelchair who can play this role? And so really thinking about your framing statements and thinking about coaching your SP, and also broadening where you're recruiting from and who your partners are. So they're there. I've actually encountered, there's folks that they've partnered with group homes, and caretakers have brought folks in that have been our SPs in those simulations, but you had to look further beyond just your SP program or just those that or the professional acting community. I'm near New York, so there is a acting community, but I have to look way beyond that to really get that diversity in my SP pool and get that representation that we need. The other piece I'll mention here in this when things have changed in the last year, 2 years, the challenges of people feeling safe to be SPs. So we do a number of transgender education simulation, LGBTQIA simulations, and right after some of our changes in the United States on our administration, there was some hesitation and of like, well, are we going to be safe coming in and playing these? And so we had a hard time recruiting, even though we were doing that larger, broader recruitment. And so we had a lot of conversations of, is it okay to have someone play this role that doesn't hold that identity? And it was like national conversations, so like the president of the Association of Standardized Patient Educators, is that okay? And if we are going to go into that space, how we're going to keep this authentic, and what is the debriefing going to look like if the SP is not holding the identity, and now we're talking about these issues that impact the specific community. So being very deliberate and thoughtful to say, and I say all that to say there wasn't a right answer, but it was more about the fact that you had to think about it, to not just tokenize or stereotype the SPs as even in your recruitment process. Which leads right into the danger of relying too much on a marginalized population to do the teaching, right? I feel like a number of us look like we're people of color in this room, and we've been in that space where we're doing the teaching and it's not your role at times, right? And that burden and that minority tax is real, right? So thinking about that for your SPs, I think, in that recruitment phase is really important. And then, as was mentioned before, this is not a hey, surprise simulation. Being really clear with those that are helping you and that you're partnering with in these simulations, the SPs and actors, about what is going to be expected of them. And and so if the simulation is a patient, racial bias and the ED is the topic, we want them to be prepared and have that space. And I'm going to talk about how to pre-brief and really lay that foundation and really disclosing it. So we disclosed it when we were doing our simulations, and we were specifically recruiting, it was anti-racism. It was actually very specific to Black men in the neonatal ICU. We were very clear when we were recruiting what the expectations were, because it was at a very charged time, and we knew the emotional labor it would require of our SPs to do this scenario. It was literally during the trial of George Floyd's murder. And so we were very deliberate in being very clear upfront in that recruiting process. And then going into that second part of this, the training process and the briefing process was really important, because we were now putting them in situations, and I'm being really frank because one, it's a small group and I think we're all on the same page here. Our learners were all white nurses. Literally, we were training a neonatal ICU of 300 nurses who are not all, mostly young white female nurses. And so being very clear in this training process and preparing them for some of the responses, the things that would be coming up in the simulation. We spent a lot of time with our SPs in that training and pre-briefing period, defining really clear anchors for our SP. This particular case is a father who's really upset at the bedside, and actually working with our SPs even in our case writing. So thinking about we all have our own biases, and we're also wearing so many hats, right? So I was coming from physician hat, I had a colleague who's coming from the nurse hat, now we've got our SP, and we write this case, and we wrote in there trying to anchor, right? So the training needs to be really clear, behavioral anchors for our SPs, and we had written, you as the father, never make any aggressive moves. It was some words that we use, like don't make any moves towards the nurse. And our SP was like, that, and I'm really glad we created this environment in the training where there was this co-creation process where someone from the community could be like, hey, that itself is kind of perpetuating a bias in just how you wrote this case, right? This was many years ago now, but still it was really awesome to have that co-creation piece during that training with our SPs to make sure we're not perpetuating any biases in how we're portraying this case, how the SP is going to be portraying it, and that they're comfortable playing that role and being in that space when you know your learners are going to come in and you have no idea what you can expect from your learners. And so, and practicing and having that portrayal really have some clear guardrails was really important in that process. So training and then the pre-briefing in terms of preparing them for who their learners are, what level of learners. So it wasn't just the identities of the learners as, hey, these are nurses in the neonatal ICU, but these are novice nurses, or these are practicing providers, really made a difference so that our SP was very prepared for what does that look like and who our facilitators were. And having a relationship with the facilitator was also really important for our SPs. So using that training time and the pre-briefing time to really embed that. And so it helped to really mitigate some of the emotional spillage that can happen for our learners in that live environment. This piece, I think, comes in that briefing or debriefing almost, right after the rehearsal. How did it feel to portray that character? Were there any moments where you felt unsure about how to respond? Let's talk through any emotional charge in the role before we do it with the learners. Really important in that pre-briefing space to do that, and then do it again in the debriefing. My colleague and I, when we would run it, we would rehearse it with variety of possible responses. So someone who's doing really well, and so how are you going to respond? Because this was an escalation case as well. So how much did they de-escalate? But also saying the crazy things some of our learners would say, so our SP is prepared. Which leads me to the psychological safety. Yes, please. Yeah.
So when you're talking about recruitment and hiring, it sounds like there's a lot of like guidelines of how to pick your people, but like what are your recommendations on how closely to match your actors to the demographic?
The identity, yeah. So, and that's, I think, what I was trying to get at is that it's, I mean, my recommendation is probably to match pretty closely, but I also know that that's really challenging. And I also think it depends on your objectives. Because, again, the goal is not to re-traumatize, right? So I've seen the whole spectrum. So on one side of the spectrum, I've actually seen, when you mentioned doing real cases, I've seen a simulation that was done where this person, the person who experienced the microaggression in the emergency department was the one that played that role in the simulation, like multiple times. You can see my facial expressions. It went really well. They actually published it. I don't know that I would have done that. Because to me, I was like, wow, like that's intense for that person. That person, I actually talked to them. I wasn't the one that ran that, but I knew them, and they were happy to do it. And so I'm really interested in doing more research on this, because there's this whole spectrum of folks who, some of my SPs have said this is awesome because it feels like I'm able to make a difference in something that I've experienced my whole life. Some have said it as like it's like trauma dumping, right? Like I get to put that energy into something. Others may say that, and then in the sim are re-traumatized and realize, oh, okay, this is a lot, right? We had SPs who had to walk out in a sim because just the thing that was happening where they kept messing up her name has happened in real life, and she's like, I just couldn't take it because they just weren't getting it. And then I've had folks that just can't play that role, and we've done creative things where instead of them being an SP, they observe the simulation and then they participate in the debrief, right? That person with the lived experience. So I think there's ways to do all of it, right? So to your question, I don't think there's a right answer. I really think it depends on all of those factors and what your objective is. I do think being very careful, like when we chose to cast someone in a simulation that did not hold the transgender identity of the case, we actually we did a little focus group with our transgender SPs because it is also, they were concerned. Like, this is another issue when I talk about SPs, right? Our transgender SPs only being cast in the transgender SP cases and not across our curriculum. And so they're like, well, we have this piece and now that's going to get taken away from us. And also worried about the authenticity. Someone can't represent a certain perspective if they don't have that lived experience. And so we held that focus group to talk about, are you okay with us doing this? We don't have enough SPs. One, can you help us recruit more? And two, how should we go about doing this? And then there's certain identities you just can't do that. Like, I really hope you're not going to have someone who's not a black man play a black man, right? Like, so I think it depends and can vary. It's a really good question because that's a hot topic, I think, in doing these sims. Did you have another? Oh, no. I think.
No, just like thinking about from a logistics standpoint.
Yeah.
I think it's
Yeah.
hard.
It is very hard.
I wanted
Yeah.
to I know my husband once was like a ultrasound model and had no idea. Like he's like, oh yeah, I just did an ultrasound my belly, right? And then they were ultrasounding his prostate with med students, and he was like, this is actually awful. Like, how do you I mean, it sounds like you kind of talked about it a little bit, but
That's a very intense example. But how do you prepare them?
Yeah, he had no idea that it was going to feel like that invasive until he was already there, and then how do you lead? What's going to bring him in? He just doesn't volunteer for stuff, which is unfortunate. But so is there specific way that you coach people of how to gracefully exit?
Oh, like if they're in the middle of some, yes. And I don't know if I say that in here. I think I get into that in the psychological safety. Yes, I always embed a safe word. So like that SP that had to walk out, we've got a safe word that they can use in the simulation, and all our facilitators know that word. For that particular simulation, it was aggravated, and so if they said I'm aggravated, that meant for the facilitators that's an immediate pause, and our SP gets to decide whatever, they could stay there, head down, or they can walk out of the room, whatever they need to do in that moment. And yes, so having that, and also having a very, having someone there to do the pre-brief, and if they do have to walk out, someone there that can meet them, which can be really challenging logistically. And so we found creative ways to do that, like someone available by phone, or we had 2 facilitators for all our sims, so one facilitator could walk out if needed with our SP. And so, but yes, I think coming in, and I think that's also the piece that I was trying to say, is that some might say, hey, we really want to give back, we want to do this sim, and then they get in it and it's like, oh man, this is wild. Or, I just experienced this. We had an SP one day who came in and they literally experienced at our front desk the profiling, and then they went into this sim, but then they stayed in it, and then they shared that in the debriefing. So, but everyone's different and where they're showing up that day. We would do a little, like, as I was walking my SP up for these sims, I'd ask them, like, how are you feeling today? And just making it easy, right? Just give me a thumbs up, sideways or down, just so I have an idea of, like, where are you showing up, because these sims were intense. So, yeah.
I think depending on your level of experience of working with SPs, like for us, we have a whole center and a director of SPs. And so she's an just immensely valuable resource because, before we even run a scenario, be like, hey, this is what we're thinking about doing. How can we best utilize? And so I think developing that relationship, having an open dialogue, having things like community norms, and really like,
Yes.
And we'll get into this some in our piece as well, but doing things every time so that when you're doing these more specialized things, it doesn't seem out of the ordinary. It's built into your systems, and everyone kind of expects, like, oh, we may just pause this at some point.
In the sim, you mean, like we may pause the sim?
Or,
Yeah.
in the briefing, or
Yeah.
I think, my question about psychological safety was about the learners.
Yeah.
Because we, at our institution, our sickle cell patients and advocates approached us about doing some didactics and potentially using or having members of our sickle cell community be a part of that. And our education team was really concerned about our learners' safety in being able to, I guess questioning how that psychological safety of a learner would be potentially harmed, or how we could really, do that in a way that preserved a lot of that safety that we spent a lot of time building, especially in our simulation program.
Well, that's what I was going to say, right? Sim inherently, we have such a strong focus on establishing psychological safety before any simulation. To your point just a minute ago about the norms, right? We've set these norms that in simulation, you're doing a very clear pre-brief and establishing these norms of psychological safety and what people can hopefully feel comfortable experiencing. We've set the same standards for our learners, where if they felt they had to walk out, they were allowed to walk out. And I think that that's really important, that whole space being, right, you talk about the safety container and simulation. And we moved our language, though, from a safe space to a brave space in these JEDI sims. And I think a number of us that are doing this work have moved from saying, hey, we're creating because in simulation it was very common to say, hey, this is a safe space to do, to learn. And I think moving from that, especially for JEDI simulations, I think is really important to say this is a brave space. And our goal is to allow for that safety, but also we're going to be uncomfortable. It's going to be uncomfortable, and if you ever need to step out, that's okay. And you're going to have the other piece we put in our norms, or like our ground rules at the beginning, is you're going to have a vulnerability hangover tomorrow, which is also real for our learners, or our facilitators, or our SPs, for all of them. That piece of, wow, we just talked about something really heavy, and then you leave and you're like, should I not have said that? Like, who was in the row? Whatever that was, how did that land? So all of those pieces. Thank you. Yeah. That makes a lot of sense. So yeah, this was the piece about having a safe word for your SPs, or having some way that even mid-sim they can walk out, or there's a way to keep that psychological safety for them and for your learners. I think it's a little easier for the learners to be able to make sure you're saying, hey, you can walk out. I think the SP mid-case, just walking out would be challenging. Going back to this slide, I think being very clear, even to create that psychological safety for the SPs, this piece is on the back end when they come out of that scenario, because we all know, like even thinking about, I know we're all in emergency medicine, right? And so you're coming off a shift and overnight, and you're like, I'm exhausted, I'm gonna go to sleep, but your heart rate, like you saw something wild just at the code right at the end, right at 6 a.m., you're about to leave. And so just thinking about where your emotions are physiologically, even if this SP is coming out of the case and they know, hey, that's not me, physiologically, their bodies where they are, just thinking about that and having a plan for that is really important so that you're not burning them out. And we used to have a worksheet that said, you know, what things about the character are similar with you, what things are different, and what are you going to do to, you know, what's different about you and this character that you played, and then what are you going to do to shed this character as you leave from the simulation. And so I think that whole thinking of psychological safety, I think we often in simulation think of it in the pre-brief, in the case, but thinking of it all the way through is really important. And how are you helping your SPs move through all the way to the end as they're leaving is important. And so that's the feedback and the well-being, right? Doing an emotional check, keeping it simple. You could do a 1 to 5. We would do the thumbs up, thumbs sideways, thumbs down. And then allowing them to, what we did was we would allow them to leave the simulation. So there's 2 pieces. Allow them to leave the sim before they gave feedback to our learners. So they had a moment to gather and reflect. Like imagine when you've just experienced something, although yes, they're doing it in the simulation, experience a case, but often they're, you know, identities were intersecting, to just gather their thoughts, to be able to give feedback to these learners, and then they'd come back in and give feedback. And then after that, after all of that, having a space to just shed that character and to think about, well, how did the learners respond? Was it what you expected? Was it not? And really closing that entire loop. Because we want them to come back, right? Future readiness. We want them to be able to continue this scenario. The other piece, actually, as you mentioned, having SP program, they're really good. If you have an established SP program, they're really good about understanding just that safety, the psychological safety, emotional safety of our SPs. So often there's already rules in place of like they can't do a specific case more than 6 times in a row, or and not even emotionally charged cases, just in general. Like it's hard to do this many. So they often have those guardrails. And but if you're not using an SP you're not utilizing an SP program, but rather we didn't have an SP program when we did these. So I was hiring people from our community. So basically we ended up creating our own SP program through this work. But creating those guardrails was really important. Like how many learners are in that group? How many times are you going to repeat this case, especially if it's an emotionally charged case and you're addressing a topic that's challenging, I think is really important. Yeah?
So for instance, you talked about recruiting people from the community itself. Like not a lot of institutions have access to SP programs. I feel like most of the institutions actually don't have access to SP program. And if you want someone to play whatever role they want to play, you don't want to feel like I feel like I'm always mindful of the minority tasks. Like I don't want this person who is from X, Y, and Z minority like to play this. I don't want to ask them to play this role because I don't want to task them with that. How do you approach that?
Yeah, I think that that's really important, that we didn't have an SP program and a lot of places don't. And even if you do, they're really expensive. And so we had access to one and I was like, oh my gosh, it's like some crazy amount per hour. So I think that piece about being really clear up front what you're asking. So even when we would advertise for our roles, we were really clear about what is it this case is going to be about. We were like, we're teaching healthcare professionals bias interruption skills or about anti-racism. So it was very clear what they were signing up for. And often we got SPs, again, thinking about that spectrum of people that really want to do this, even though they've experienced it, and some that don't want to because they're experiencing it all day. We often got the folks that were on this end of that spectrum of they actually wanted to be able to give back, and because that identity that they held had experienced so much, and they're like, this is awesome. Like I had this terrible healthcare experience and now I get to go in and help teach healthcare professionals. I actually got very positive responses from a number of folks, and I see you shaking because I know you have a lot of experience with this as well.
Yeah, and definitely, I mean, we have an SP program, but then in trying to fill a lot of the roles we were doing, we definitely went into the community, and I would go speak to groups, and you know, so I'm there, they see them.
Did you go to their shows as well? That's what we would do. We would go to their shows.
Now there's a new show. When we recruited from the acting community, we have a new one over at Ben Lowry, a new show. But I would go to, we needed some actors for disabilities, and so I went to one of our deaf community advocacy groups, and they were there, and just asking, and it was amazing. Most people just really wanted to do it. And once
Yeah.
heard that, you know, I'm here at your group because I understand the disparities and we want to teach healthcare providers how to do it, it was just overwhelming the
Yeah.
response.
They're so excited to want to teach about it. And we had a similar, so for exactly that, we went to a group home, folks with CP, because they were doing some cases. And the other piece, though, that makes me think of that I don't think I covered, but you're partnering with them, right? They're part of the curriculum, but you're also utilizing their expertise. And so being very mindful about how do you compensate them for their time is really important. And sometimes it can be really complicated. So when we had those folks that were coming in their wheelchairs, they were so excited to do it. These were incredible SPs. But we weren't allowed to we weren't allowed to give them money for it because of it would impact they were getting like Medicaid. There was something about how their benefits would have been impacted, and so we weren't allowed to give them money. So finding other creative ways to compensate them for their time was really important. You look like
Grocery,
yeah.
Grocery gift cards.
Yeah, exactly.
Gas
Yeah.
gift cards,
Yeah.
we did all,
Yeah.
Now gas gift cards.
Gas, man. That's right. That's what people need. So I think if you're using SPs for the JEDI simulations, I think all of those pieces are really important, really good questions, right? It's not easy. It's really challenging, but being mindful and thoughtful, and then partner with people who have that experience. Call me, call Jackie. We're happy to help. We love this. This is like I wish there was more. I think my goal is to do a little bit more concrete, like research, gather some data from our SPs, from our communities on what is this experience for them and how is it most useful and how can we make it better. So psychological safety, I think, is the biggest piece throughout the entire process, and really thinking of SPs as your partners and not as you are using SPs. So even though I keep using that language as well. All right, I will pass it on to my partner here, Dr. Mundo.
Thanks for that, Sabrina. I'm learning so much. How we help put this together. It's kind of cool. So I'm going to be presenting on behalf of Dr. Mariera. She's an attending also at Denver Health that does a lot of our sim work out there. And really, we're going to be talking about the simulation approach and design. And I think this is kind of like, once we have selected our topics, once we've recruited our SPs, and this is kind of that next step, right? Like, how are we going to execute this? And so ultimately, most of us were trained to think about simulation in terms of modality, right? So we're thinking about mannequins, we're thinking about standardized patients, virtual reality even now, I think it's starting to come into play. But that framing actually breaks down when we move into equity, communication, and team dynamics. Not because these are like technical problems, but mainly because they're behavioral ones. And so while simulation actually is well suited for these high stakes interpersonal challenges, we don't have a standardized approach for how to design them well, right? So we need to make that shift, not about what should I use, but exactly what behavior I'm trying to change. And once you answer that question, the design becomes much more clear. So we want to move from modality to mechanism to outcome. So based on that, we created this SimAlign framework, which stands for Simulation Alignment for Inclusive Learning and Growth in Non-Technical Domains. And the reason that we created this is because it explicitly sits at the intersection of simulation science and also an equity-focused education. And conceptually, it's a framework that we created, but it's also a tool. It functions like a tool. And so it gives you a structured way to be able to align the simulation design with behavior-focused learning, particularly as it pertains to very complex, high-stakes clinical environments. Specifically, it's designed to assess for domains that are harder to teach and assess, specifically things like communication, bias recognition, allyship or bystander behaviors, and also systems awareness. So now what we're going to do is we're going to walk through this so you can see how it's used in actual practice. And so the way that we use the SimAlign framework is through these 5 different steps, which we'll kind of go through, and also it's part of the toolkit there that you have. And so the very first step, we kind of keep going back to this, is like, what is the target behavior? And the nice part is that this is actually already going to be done for you when you do your topic selection, right? And so this should already be something that you have already thought about, but you're going to refine it a little bit more here. So first of all, what do you want your learners to do differently? Do you want them to recognize bias or microaggressions? Do you want them to respond in real time to these things? Do you want them to be able to reflect or debrief effectively? You want them to learn how to navigate system constraints or other, right? This isn't a exhaustive list. These are just a couple of options that are out there. And based on that, you can consider what kind of mechanism you're really trying to address. And so whether we're talking about recognition, response, reflection, system navigations, that's really gonna help you identify what type of learning behavior you're trying to influence. And so step 2 is that you want to match the modality to the mechanism. And so the big thing here is that the standard participant isn't fully only about achieving realism. It's about being able to achieve an adequate behavioral practice environment. And while this mechanism here has these example modalities, I do want to say that it could be like a mix and match kind of thing. So just because you're trying to teach on recognition, you don't always have to use a case or vignette, but a lot of times it's a lot easier to achieve that by using case or vignettes. Whether we're talking about response, learning how to respond to a certain type of behavior, typically using standardized patients is the most effective modality, but again, not set in stone. These are just some suggestions. If we're thinking about reflection, using like a fishbowl style or group debrief, or if you're thinking about systems navigation, doing like a hybrid approach that includes a team simulation. Again, this isn't a rigid one-to-one mapping, but overall these are patterns, and in practice you can absolutely combine these depending on what your learning goal is. So for step 3, you want to do an equity-sensitive design check. And this is kind of where we're reinforce a lot of the topics that we discussed in the second step is, are we reinforcing stereotypes? You want to make sure that you're having adequate representation. Input in the case designs is kind of what goes back to what Dr. Vora was discussing in terms of co-creating with our SPs. Thinking about avoiding the minority tax and facilitation, right? And so a lot of times the only people that sign up for these things are people who care about these things, and oftentimes they are a minority. So it's really important for us to like consciously check as like, hey, are we actively trying to avoid the minority tax as we're doing this? And then also making sure that you're explicitly integrating your psychological safety. And this goes back to psychological safety for your standardized patients, but also for your learners. The next thing is debriefing strategy, which we'll talk a little bit more about moving forward. But you want to make sure that you're including some micro debriefing into this. You want to also consider doing some structured debriefing, especially if you're doing advocacy inquiry. You can incorporate some reflective writing as well, and then also peer observation as another like debriefing strategy, such as a fishbowl exercise. And the last thing is the fidelity calibration. I think this is kind of one of the more important things as it comes to designing a simulation, is really the question that you're trying to ask is, what level of realism do I need to be able to activate the target behavior, right? And so a lot of times if you overly, make the fidelity too high, it could sometimes cause a little bit of distraction, right? And so like if you have like the beeping machines and other factors that are not relevant to the target behavior, sometimes it can distract from the behavior that you're trying to change. And then also if there's too little fidelity, sometimes that can cause some disengagement. And so you always want to try to achieve, ask yourself what that level of realism you need to achieve that target behavior. And additionally, fidelity should never, fidelity should match the behavior, it should not drive it. So kind of putting this all together, we have the Similine framework, which should be included in your toolkit, and it kind of asks all these different questions that we discussed. And again, we'll be able to incorporate this. And as you can see, it's getting a little bit, it's starting to get a little bit repetitive, but that's by design to make sure that we're, not missing these steps as we're designing our simulations. Great. The next, I'm going to invite Dr. Romo up for our next section.
And I think something that I learned from the study that Jackie and her team, Dr. Ward Gaines and her team put out about their initial DEI simulation day was, you really want to keep those cases really simple, right? This is a great time to incorporate an asthma case, right? your residents in emergency medicine should know how to manage asthma. And so when you're having so much noise from this sort of new or very psychologically shaky topic, giving them that really simple, where they can just rely on their, is it type 2? Anyways, learning theory. Thank you. But shout out to that paper, because we've all made that mistake of making that case too hard. And for these cases, that will be, even if your case goes really well, you're going to spend too much time talking about the medicine. And that's what your learners are going to default to, because that feels normal for them. So when we're thinking about the debriefing, this is going to be maybe a different flow than you've normally had. And so we want to start off with a pre-brief. If your whole day is going to be JEDI-minded, then that might be just at the beginning of the day, where you not only do we always do the CMS basic assumption with our learners, but this may be a time where you let them know that, hey, today is going to be a JEDI day. Today is going to be a health equity day. Those are the cases. And to remind them, similarly as the basic assumption does, that they're all carrying fantastic individuals, and at the same time that we're going to give them the benefit of the doubt with what things come up. If you have community norms, a great time to remind them what those norms are, and especially if you have things like timeouts or different things, to reestablish those as, or if you don't have them, name them as opportunities to, if they get overstimulated, overactivated, be able to time out, whether that's pause the case or leave the room, making sure that they know those things. Once the case has happened, check in with yourself as a facilitator, right? We've already listed for our SPs how these, running these cases can be activating in surprising ways. Check in, where am I at before I go debrief this team? I'm a girl dad, trying to always get better at being a girl dad. And I find that oftentimes the things that I'm reading about being a better parent make me a better doctor, make me a better teacher. And one of the things I love from a book called Good Inside is giving someone the most generous interpretation. And my wife's like, you're really good with that with the girls. Maybe you should try that with other people. And I'm like, yes. But this is a great time in your check-in to say, hey, I noticed this thing. Before I, to bring myself down, to, recognize that it's normal to have some of these feelings, especially if, for many of us, we're minoritized or, our gender is not always treated equally. And so saying, what's the most generous interpretation of what happened? How can I walk in before I even facilitate with giving some grace? And that's going to allow you to step into that room better prepared to face that debriefing. After that, check in with your participants. I think many of us do that, like temperature check. Hey, how's everyone feeling? This is usually when our learners want to start to, use that rationalization. You're like, no, we're not talking about the case yet. I just want to talk about where you are. And we do it every single time, so that one time a year that you need it, it's there, and you can make sure everyone's back to that level of, let's get us back into a learning space. Then your debriefing is going to happen. Check in with people. How are they doing? This is a really great time to share resources, right? What's available on your campus? This is a great time to give folks your number if you haven't before, and let them know, hey, if you're still thinking about, if this is still ruminating within you, please reach out. And then check back in. If your SP left and you're a little bit worried about them, or one of your participants, or one of your co-facilitators, or yourself, right? This is a great time to reach back out, make sure everyone's okay, because we all are on, as simulationists, we spend so much time building psychological safety. We want to make sure no case destroys that, but especially where HEDG, JEDI, DEI, again, whatever the alphabet you're allowed to use in your state, when it's on such shaky ground. So in Texas or Missouri, where I'm at, if you have a case, you don't want that to represent everything that you're doing, and so checking back in with your learners is really key. Some, things to consider, anchoring back to emergency medicine, right? When you're debriefing, a lot of our learners may say something like, this case didn't seem real. Well, I based it on a real case, and things of that nature. So, recognizing that when we're stressed, when things get really, really busy, that's when our biases are going to kind of sometimes, especially if we're not mindful of them, drive how we approach things. Reminding folks that hierarchy really shapes our communication and a lot of how our EDs function. That we all have cognitive shortcuts that are amplified in high acuity settings, and then that equity really is a patient safety issue. And this is a time where I think as facilitators, being vulnerable, right? If any of you have read How to Be an Anti-Racist by Ibram Kendi, one of the things I love is from the very beginning, he's like, I was super racist. Right? He names it. We're all on this journey. And so if we can recognize that there's been times where our biases have shaped how we've interacted or how we wish we would have had these tools to better serve our patients, ourselves, our trainees, this is a great time to model that vulnerability. In fact, you may talk a bit more than you ever do during these debriefings. As Alice said at the beginning, you don't want to. This is not an opportunity to lecture, really, and usurped that really amazing space that debriefing creates, but it's really to demonstrate that vulnerability, begin that conversation, and then you can be that wallflower that really helps to drive that great learning. For your facilitation, you want to, recognize patterns, so identify common learner patterns as much as you can. We try not to typically call out individuals in any simulation. So I'm a CMS disciple. I love debriefing with good judgment. And so just instead of making assumptions, right, in that framework, we're seeing, I noticed you did this, or this happened during the simulation. I'm curious. And so really allowing our learners to, from those snippets that we witness, allowing them to share their knowledge or how they were approaching things, and then really driving that information to allow the rest of the debriefing to happen. For your strategy selection, really matching that facilitation strategies to your learners' dynamics. And that's where, it's so important that you don't give this case to that faculty member that has the least sim experience. Right? You want your best trained person, the one that's most dynamic. And if you're co-facilitating, right, that might be a great opportunity if you, don't have too many folks that are both great simulationists and great at DEI education, where you match those two personalities, right? So we could have one person who's really good at the sim portion of things and one person who's got that expertise in the DEI content. Mm-hmm. Mm-hmm.
So from a logistics standpoint of running any sort of, I just don't think our faculty currently, most of them have no debriefing training, and or we did a faculty development 1 hour thing 2 years ago. Everyone's forgotten it. They haven't practiced it. No one is doing it. Right, and I just don't know.
Yeah.
From a logistics standpoint, how to get to a better place in that.
Yeah, I'm happy to answer. It seems like some of my colleagues might be as well, and so I'll throw it out to the room and then reiterate their points so I seem brilliant. No, and then chime in with a little bit more. But go ahead.
Some of the unique things we've done to try to bolster that ability for facilitation is I actually started using some of
again, sort of, you know, working with everyone. So I started using colleagues that were doing communication in circles. And so, have you done any of this where we do the circle debrief with Christy?
Is it the, but yeah.
Yeah, and so just a different way of facilitating, and so then we have more experts in being able to do that. And so the way that they do the circle debrief, like it does not matter what the content is, that they're able to do that. So that was a way for me to bolster more people who are experts, at least in facilitating. You know, some of the things, trying to have at least one of the faculty rotate around to each of these groups that might be more of a content expert, but at least the facilitation is being done. And you know, when you have an active learner, reflective type discussion, you know, it's coming out. The issues, you know, they truly are teaching themselves, right, to do that.
We may have to partner with faculty that are outside of EM, but are like-minded, either in SIM or JEDI, so that you can build your cohort, but it may not all be EM. So you could look at family and just people who are interested in both, in either or both.
Yeah, I think, go ahead.
I think that there's just you also need some administrative buy-in. What I would do is, at least what's worked for us is that there's just been a lot of discussions with admin about the need for simulation, because then they need to actually start hiring the sim training faculty, right? 'Cause I think, and if that's not really an option, then you can discuss having your faculty attend like sim instructor courses. We host one at IMO every year, and I'm responsible for running twice a year, and so you can send them to sim instructor courses in your area. The other thing that we used to do where I did residency, we had only 2 sim training faculty. They weren't really sim training, sort of grandmother did them, but we had residents that were really interested in sim, that did sim electives or they did rotations, and they often either we had them attend certain courses, either the program leadership paid for it or the administration paid for it, and then they would end up essentially like helping us facilitate. It's not an ideal option because it's not it's sort of rotating and doesn't give you any sustainability, but I guess from the resident side of things, it really exposed them to sim in a program where there really wasn't any. But I think I would say that the next thing to do is talk to your admin about like how you need sim for QI, you need it for resident education. And if we really focus on the QI part, they might actually help. They might be more bought into getting sim training faculty.
Yeah, we have no sim trained, like I am not sim trained, my sim director is not sim trained. We both done the CMS course, but we in general, I mean, I feel like we're a relatively under academic program, and like, I guess not the most academic of academic programs, if that makes sense. With a large portion of community, like most of our residents go into the community, and most of our faculty have come from the community and or trained in that program and have stayed on. So I just feel like the logistics seem very difficult.
Yeah.
Partner is the way to go, because, you know, I'm sure they have a communications department, and some of them, they're so happy when you go and say, hey, can you partner with me on this? And they'll use that as a requirement for their students, and like I said, they have to learn these circle things, and so that is part of their ability, like their skill set, and so
it's like
they.
sim adjacent,
Yep,
right? They
yeah,
might not be sim
they're not
trained,
sim trained, but they're
but-
facilitators and trained,
Yeah,
and so.
or they're trained in the skills you're teaching.
Yes.
So we've used, so not necessarily, you might not have a communication department, but you will have things like social workers. So we partner with a social worker with that person to give them and train them on the pieces of SIM, right? Like the debriefing concept, but
have a Zoom room. So, you know, but it took time and like, why didn't I think of partnering with them before?
Yeah.
And I'm kind of in the same kind of boat like you. Like we're a newly academic department, and I run simulation for my company, which spans 5 states. So I fly in for their simulations. But the people I'm working with, they're not simulation trained. Like my facilitators are not simulation trained, and I cannot facilitate every single simulation that I'm doing. I pick the highest yield one. But what I've done is we've sent people to do the CMS courses, and then it's gonna take a longer time. But I actually have them debrief with me, like with the high stakes case, and they will learn and pick up on behaviors. I send them a pretty long debriefing guide. If it's like a case about validation or microaggression, whatever the case is, like these are like the expected reactions, and this is an example how you respond. So the lights just turned on. And then we got
Brought the light.
Yeah.
And I had a piece too, so, go ahead.
Yeah. Other thing is wellness coaches. Like if you have like physician coaches, those are actually good resource too. That I've partnered with them before.
People who have the skills, right? And
Yeah.
maybe aren't.
I think there's a question of readiness as well, right? And I think for all of us, whenever we're venturing in this work, whether it's recruiting individuals who are more diverse than the places we work, or engaging in education and saying like, okay, what are we ready for? Because I think, you know, not letting perfect be the enemy of good. And so you may not jump into the most difficult DEI-based case, but you may start really simple with, you know, or disability, you know, something where, and then I think, you know, leveraging your community partners on your campus. You said you were in Dallas, if I remember correctly, San Antonio. So you have other institutions in the area. And so seeing what's around, and I think for myself, I'm so glad I found the DEI spaces, both in emergency medicine as well as in my own community, because they've been so necessary. You know, this morning before some of you showed up, it was just us as facilitators. It was like, it feels so good to be in a space where I can talk like this. And so I think what you'll find is if you challenge yourself, because it is a challenge, right, to say, who else is here? What you'll find is many of you are in the same place of needing others to do some of this work together. And I think you'll be enriched not only for that case, but in general for this work.
I just wanted to add, when I participated in Bending residency, we had a case that I think worked very well, where we actually got our interpreter to partner with us. And she'd been in our ER for many, many years, saw the good, the bad, the ugly, has had just like a wealth of knowledge about the issues of like adequate communication access in our ED. And so she was somebody who we partnered with early on in designing the case, and then she became like just a very natural co-facilitator. And even though we didn't ask her to facilitate necessarily, just introducing her to concepts of like, I noticed you did this, like tell me more, etc. Just like she kind of just took the lead on the whole case, because that was really her area of expertise, and it was very well received.
Yeah, the next time we're in San Antonio, we'll just have to reach out and see if, you know, if things align. But continuing, you know, making sure that your language you know, the language we're using helps maintain that psychological safety. If you do have a debriefing guide, keeping it simple and making sure that, you know, the facilitators really engage in building that psychological space. And again, as a guy who can put his foot in his mouth from time to time, oops and ouch are great, so that when we do say something or, you know, make an observation that, gosh, maybe that was a call out, let me rephrase that, or just acknowledge, gosh, that may feel like a call out, I'm really sorry, I'm just really curious about this one piece. And so, again, anytime you're not always gonna be perfect, and so when you demonstrate those other skills of recovery, of acknowledging, of that humbleness, that's also teaching some of these skills to your trainees as well.
get right into it. I'm Smriti, for those who didn't catch my name. In terms of actually debriefing and facilitating, there are quite a lot of hiccups to be expected with JEDI simulation in general. And it helps to have a sort of a prompt bank in mind, some language that you are already familiar with, but also to kind of have a strategy. So in general, as Ernesto was saying, try to recognize your learner prototypes and try to match a facilitation strategy that works for those particular learner dynamics. And then have some language that matches those strategies, and that's what I'm going to go over. So this is a complex-looking heat map that groups learners into 4 quadrants of a little bit of some challenging prototypes, essentially. And you don't have to memorize any of this. You can absolutely take a picture. But in general, what it tries to do is you have learners that are very activated or not activated at all. And then you have learners who participate very aggressively or so much that there's no space for anybody else. And then there's people who don't participate at all. And this grid tries to match, you've got activation on your y-axis and then participation in your x-axis. Obviously this is not an all-encompassing grid, right? There are thousands of different kinds of people, but these are this just kind of groups your most challenging learners into a few broad groups so that you can simplify the debrief in your mind. So looking at that first grid, that's someone who isn't participating very well, but is internally very activated. Those learners can be challenging because they have a lot to say and they're feeling a lot of things, but they're not really discussing it. Or they'll just drop a little bit, they'll drop a bomb and walk away, right? And there's a lot that you can flesh out from them. What this typically looks like, someone who is very activated and but not participating much, they might say something like, this just doesn't happen where I'm from. Like, this doesn't happen at my hospital. They might not really flesh it out more. They might just mask their activation by saying, like, I'm really sorry, I don't want to say the wrong thing. But actually, there's a lot of stuff that they want to say. They might just, deflect. They might avoid eye contact. There might be some defensive body language or a lot of subject changes, kind of just focusing on the medicine of it and just ignoring, the entire JEDI aspect. Next to that, you've got someone who is very activated, but also participating a lot. And this is I think all of you can expect that this is the prototype that's going to destabilize your room the most, right? Someone who's just defensive and skeptic, like, what, you can't say anything these days, or, I've literally heard that so many times. Or if a microaggression is depending on impact, then anyone who's sensitive is gonna say I'm being a microaggressor, and they can just be argumentative and they might have some strong emotions. And I think that those are, yes, they're your more destabilizing learners, but that's also the group that you are really just doing the simulation for, right? You need them to kind of get onto your page. On the calmer aspect, right, those are a little bit easier to handle. You've got your participants that are very, they have a lot to say, but they're calm. And that will often show up as someone who's just taking up a lot of airtime and not really giving anybody else any space to talk. Someone who wants to tell long, winded stories, but the story doesn't, you don't really know where it's going. The other part of it is someone who's just very much focused on concept and theory and doesn't really know how to translate anything that you're saying into something practical. And so you have to organize them. That's really you have to organize them. And someone who's not participating and is also calm, they're just your quiet people in the corner. Either they're just not really engaged, or they might just be really shy. Or they're the type of person that's just introverted and reflective, and you really want to hear from them because a lot of them actually have a lot of really interesting insights, but they're just too shy. Or if there's another person that's really talkative, they're going to end up kind of quieting down. So how do you address that? That's the whole point of me standing up here, right? So your low participatory, very activated people, Someone who is kind of minimizing things, you know, like, oh, this just doesn't happen here. I don't really think this is a problem. Try to reopen their cognitive bandwidth. Certain things you can say language-wise are, it seems some people recognize certain patterns, others recognize other patterns. What do you think influences what somebody notices? Let's explore the possibility that it's rare, but that could also happen, or that it's just underreported. What would that look like? So there's a lot of, you can ask these sort of redirecting questions that get them to open up their mind to other perspectives. Someone who is just kind of over-apologetic, doesn't really want to talk about what's going on, but just like, oh, I just don't want to be wrong. Try to bring that psychological safety back into mind. This is a safe space. There's no right or wrong. We actually want to hear from you. It's a practice space. It's not this is not performative. Someone who is kind of like defensive, shutting down, has like calculated short answers. Don't call them out directly because that's going to make them even more defensive. Just widen the scope of the question. What perspectives have we not heard yet? If someone were uncomfortable in this situation, what might be driving that? What might make it risky to speak out in this particular situation? And then, the very common one is, this feels like we're blaming attendings. We're already so stressed out, and we have to take so much responsibility for so many things. And I think that's when you can talk about, we're not trying to label individuals at all. It's just about understanding patterns that affect patient care. And how do you think having these discussions in this safe space will make it less difficult or reduce that cognitive bandwidth that you're talking about in real time? Someone who's, very activated and participating a lot, that's the learner that we're all kind of a little bit scared of as debriefers. I think one of the hardest ones I ever had was I ran my upstander workshop with a group of psychiatry attendings. And they were not bought into the subject, and they're psychiatrists, so there's like that verbal warfare. I was very proud of myself for how I did, but it was a lot. And you have to slow the room and bring that energy down because there's a lot going on over there. Try to depersonalize it. Go away from like the me versus you and pattern versus system. You can refocus on that CMS basic assumption, right? Like, let's assume good intent and rather just focus on examining impact. Or what structures amplify this dynamic. Whoops. I really struggle with technology in 2026, and I think everything that I've ever made fun of my dad for, tech-wise, is going to come back and bite me. There's often their defensiveness and their activation is coming from a place of feeling defensive. They feel personally attacked. So I think we have to separate that identity from action, right? And you can actually say that. Why don't we separate identity from action? How you come up, how you show up in a interaction that's under stress, under anxiety, under literal life and death, it does not define who you are, right? All it does is it just shows us a pattern of how we all deal with like pattern recognition in the ER, and the space is meant so that we can work through it. We can always anchor it back to patient safety, right? The whole point of this is that poor communication can lead to patient safety issues, so equity is a patient safety issue. We want to try to, that's what we're kind of focusing on. Someone who may bring this I think the political statement is very, very common, right? Like, why does this have to be political? And you can say that, well, I can appreciate that you see this as political. For others, it may be personal and political. How can we hold space for both? And if the tone starts to escalate, you can start to say things like, I want to make sure that we're hearing each other. Let's take one breath before we continue. Or I'm noticing energy rising. That tells me that this matters. It's making us uncomfortable. This is what we're trying to get out of this session. And then you're going to have people who are going to really focus on the evidence. They're like, oh, well, show me the literature behind what you're talking about. And you can, I think you have to refocus those people too. There's literature and bias and outcomes, we can talk about that. But for now, let's explore this case and what's coming up for everyone. Because you don't need a sim session to review literature, right? You can do that at home, but we're trying to talk about behavior change. And then the other part of it is just the victimizing learner. So I'm spending a lot of time on this piece of the grid because it's the hardest one. You have learners that are just like, I feel like I can't say anything anymore. I feel like I am being singled out because I look a certain way. I think it's, again, try to depersonalize. Like, no one's saying that. We're actually trying to open up options rather than shut you down. We're not trying to restrict speech. We're trying to expand our communication options. We're building tools. We're not removing them. I think the key is to validate their feelings without endorsing what they're saying. And that can take some practice. I think that if, worst case scenario, if you're really feeling heated up, you can say, how about we return to this in a minute, right? Why don't we take a minute break? Let's kind of like reflect on what's going on and come back to it. Your low participation, your like quiet learner who's calm and you're not really sure if they're just not interested or they're just shy, you can try to make some eye contact. Things like, okay, we haven't heard from this table. Who's, what's going on over here? You might have people who might just be neutral and say like, oh, I can see both sides. I can see how, this person may have interpreted this wrong. You can kind of lead with curiosity to get them to flesh out those thoughts. Like, so what do you think, you said you can see both sides. Tell me what those sides are. Kind of just get them to talk a little bit more. Because I've noticed that once they do start speaking, once they realize that people are actually listening and like your body language shows that you care about what they have to say, they're more likely to keep talking.
Can I ask a question?
Yeah, for sure.
For these types of cases, what participant group size would you recommend to really kind of let's say you have all of these learners in the same group. I'm imagining a group of 15 people is way too much.
Yeah.
To kind of effectively reorient some of these different types, especially like the louder ones or the ones that are shutting down more.
Yeah, I would say the ideal size is about 5 or 6.
5 or 6.
Yeah, I've done it with 8 people, and then the session I was talking to you about, the psychiatry attending one, that was like 15 people. The way you structure it will have to change based on group size, right? So your small groups, like your SIM debriefs, you can do, I think, 5 to 6 max, right? But when you have big groups like that, the best way to do it is, that time what I did was I actually had 2 videos that we created that were a minute long. Just 1 minute showing the microaggression, that's it. And then we did like a group chat about the video itself, like what are the microaggressions that you identified? What was the third person, right, that bystander? Why did they not speak up? What were and then afterwards we did these, like, we broke them all up into small groups and then had them like role play the video. So my point is that you have to adapt to your learner size, but ideally in a SIM session, say you're trying to schedule your faculty, schedule your residents, try to have it be no more than 5 or 6 learners at a time. Yeah, that's a great question. This actually came up for us yesterday because we weren't sure how many learners we were going to have today. And so having that adaptability is definitely crucial.
Can I ask a question real fast?
Yeah.
I feel like you kind of already touched a little bit, but I was wondering if you had an example, like if you have a learner who like says something that you feel like is threatening to the other learners, like that you feel like, you know what I mean? Like I feel like I've seen it go both ways where you don't address it, and then everyone feels like you weren't protecting the other learners from like, a harmful statement.
You have to address it. Yeah, you can't, if there's something that someone's really stuck on or there's a harmful narrative that shows up, you have to address it. If they're harming other learners, is there a particular example that you're thinking of?
Like the one that comes to mind wasn't during SIM, it was like a patient said something racist to a medical student and or it was, I actually don't remember what, but the attending just was like, had the student leave. I was like, oh, like, let's not continue this interaction. Why don't you go and I'll like talk to them some more. But then the medical student felt that like by them not addressing it, it was like
It became like a bigger thing, actually. It was perpetuated.
They weren't being protected from that interaction.
Yeah, I think how you deal with it with the patient versus how you deal with it in SIM with the learner. They're fairly different because with the patient interaction, the most important thing is like you need to de-escalate and then you have to protect the junior person that's there. And then you also have to figure out, like, does this patient have capacity? Like, is this a demented patient who's losing it? And then you have to obviously address it. In SIM, it's a little different because you can't shut down the learner. With a patient, I can say, we don't tolerate that kind of language in this hospital. And this person is a respected doctor, et cetera, et cetera. If you tell a learner in front of everyone, they might just get up and walk out. So it's, you have to de-escalate the situation first and say, well, let's try to, you know, remember that we're all trying to do our best here. We all are here because we want to learn, and let's just make sure that we have some mutual respect for each other, because I certainly don't want to say anything that will upset the rest of you, and I would hope that you all have the same respect for each other. Kind of keeping some sort of basic assumption. You do have to draw that boundary a little bit. I think that's when you have to set down that, like, you know, this is we're not gonna tolerate it, but you're saying it in a way that includes them into that basic assumption of, like, we all have this responsibility to maintain mutual respect. Does anyone else have any ideas on?
I think I agree. Real life patient versus learner is a little bit different. I think in the learning situation, that's why if you start with like the common cause or like the group's rules or whatever you want to call them in the beginning, you can say like, let's take a pause here. Let's remind everybody about our team association or common rules or whatever you labeled it in the beginning. And one of them was that we allow everyone to speak and we remember our mutual respect for each other. Because usually those are included in your rules. So you can be like, let's take a moment, review our rules, and everybody take a breath. And let's remember, you know, everyone's entitled to kind of share how they experience this scenario, but we want to make sure that the speaker is heard and respected, and that the other learners are respected as well, and they get a chance to answer from their perspective.
Yeah.
And then I also agree, in real life with a patient, I actually had that same scenario with a resident, and I was standing outside of the room, not really even sort of, she was a senior resident, so I wasn't supervising, but then I heard the incident, so I stepped inside the room, and I was like, you know, sir, same thing, this is a hospital where all the doctors have met their requirements and are fully accredited for, or meet requirements to be a physician here. They're all high-level physicians. You are always welcome to stay at the facility or go somewhere else, but here we speak to each other in a respectful manner. And if you feel something was going wrong with your healthcare, please let me know right now. Happy to address it. If it's a matter of something to do with this person's identity, that's not tolerated at this facility. So we're both going to step out. We'll give you a moment. Circle back in 5 minutes and let me know what you decide. And then I can be like, all right, we're going to I was like, great. Let's pause. Let's start over. I'm going to have her come back in the room, and I expect some respectful discussion.
Yeah.
Yeah, and I think if it was as egregious as that in a SIM, I feel like probably I'd also meet it with, that's not tolerated. You know, I think it's one of the things that's so powerful about the oops and ouch, right? Because it's, and one of the things that, you know, I've struggled with in the past is, what if I witness something, but my learner may not be comfortable with me speaking out for them? And one of my colleagues at WashU, who's brilliant, he's a physical therapist, just such a great resource on our campus. You know, one of the things he shared is like, I don't, you know, I speak for myself. Like, it's unacceptable to me that you've spoken to this person. Like, I'm not necessarily, like, yes, I want to be respectful of that person, but just for me witnessing it, I need you to know, right? Which I think, again, Julian's like a bit more, he's on another level in a lot of this work. But I think, you know, oops and ouch, and then allowing that person to rephrase it, or, you know, I think as the moderator saying, gosh, you know, I think if if you obviously recognize that the room is responding to something, I think not labeling it is, you know, I don't let anyone leave a simulation having done something dangerous, that if they did it in a real medical case, they would do harm. And similarly, in communication or whatnot, in these scenarios, we'd also not want them to leave thinking that either that was acceptable or that we tolerated that. Because, I mean, talk about damaging the psychological safety of this work, especially.
I think that if it's egregious, so I agree and disagree. And the reason I'll tell you why. So I agree that there have to be some boundaries that you have to set. But I also think that if the whole point of you is to not be preaching to an echo chamber and to try to influence behavior change, I think I would challenge you to figure out a way to talk to this person without just being like, I don't tolerate this, get out, right? So I think that something such as like, all right, we're trying to examine behavior, we're not trying to let's not attack identity. Or, you know, I appreciate that you're feeling very intensely about this. That's where you use advocacy inquiry. I appreciate that you're feeling very intensely about this and is bringing up some stuff. Oh my gosh, I forgot what I was gonna say. But you know, I wonder if this is risking shutting down conversation. And I wonder how this is affecting your colleagues over here that you work with every single day. It's a little bit.
About how to deal with that sort of thing, which also included discussion about the attending taking the lead versus talking to the person who received the comment and saying what exactly you said, which is almost like a very quick debrief and then saying, how would you like to handle it? Do you want to address this issue? Do you want me to address it? Do you want to table it? We'll come back and debrief further later. And so some of what you're saying and what you're saying, I actually learned from Dr. Gaines about that scenario. So, you know, I was joking earlier when I said you have to do a sim of a sim. You sometimes have to do a sim of a sim to talk about should the person talk, the person affected be like, I'm going to talk to the patient, which also has its own issues because you might be so upset at the time, you just want to go in, and that's not that's a tricky thing to handle.
Yeah.
But it's also important to understand that you don't want your attending necessarily to stand in. But the med student, in your case, it sounds like the med student would have received it back, would have appreciated the senior person coming and saying something, which I think a lot of early learners do want their senior person to at least show solidarity. Like, whoa, hey, not here, not right now. So it's tricky, and a sim of a sim is a good way to tease some of that out.
Yeah.
Because it gave me strategies. My incident happened before, actually. I took Dr. Gaines' sim, but it worked in the scenario, and it was instinctive. But I was also aware that I wasn't going to, I mean, this man was like an 80-year-old Caucasian male. He's from a certain generation. Also grew up in Tennessee, communication issues. So, context plays a role. At the time, it seemed to be the right thing. I was also able to talk in a way that wasn't inflammatory, and he immediately backed down. And then the resident was able to come back in and talk. But that's not going to work for everybody. In the case of your colleague, he would have much preferred to sort of address the issue himself. But also recognizing that can also be a triggering moment for the person receiving. So these kinds of things are useful simulation.
Yeah, I think how you deal with the patient, right, is going to be a little bit different than how you deal with the learner whose behavior you're trying to change. And with patients also, there's some strategies that work for both. And for me, I really like the why question. Someone looking at me being like, oh, I thought you were the nurse. I just was like, why? This woman just looked at me and was like, You could see all everything just like short circuiting on her face. And then afterwards she's like, I'm sorry. I made an assumption, I apologize. And so sometimes just using the why question is okay. An egregious, like overt racism, I think just let that you have to address right then and there. But a learner who is just not understanding, I don't think that you can shut them down. I think you have to use specific language, such as like, I appreciate that you're feeling this way. I wonder where it's coming from, or I wonder how it's affecting your learners. Obviously, someone's overtly like disruptive, racist, like that's a different scenario entirely. You might have to just have them, you might have to talk to them later. What's that?
I think this conversation speaks to the just complexity of these scenarios and why so many, even folks who are really great at SIM and maybe also really good at DI, shy away from simming some of this because it's such a dynamic situation, right? When you anticipate what your debriefing is going to focus on, but then a case happens. And then you anticipate, based on that case, what's going to happen. But then that room has, 5+ little just individuals who you don't know what they're gonna bring. And so I think, before doing this, practicing some of these things, having a strategy, and I think our toolkit of how do we have some of that of how do we bring things back. But ultimately, I think, you may walk out of that being like, gosh, did I handle that right? And that's where you can then go back to that person and say, hey, I don't know, or even to the group, I don't know if I handled that well, right? Or the other thing I wanted to shout out to is duality, right? Like, in our white supremacist culture, we want everything black and white, but duality exists, so we can both have, I love when Dr. Desai is like, hey, I disagree, awesome, right? All of us are complex individuals, and so we're not going to see everything the same, and that's okay. And so I think even how you embrace that as a facilitator, if somebody catches you off guard, go, gosh, I'm really caught off guard. My ears were activated by that. I'm not sure how to respond in this moment to what was just said, right? And then someone in your team might be like, well, I do, right? But again, I think one of the things Dr. Desai is really stressing is maybe not having the best responses in terms of how you say things, but bringing people back in. Remind them, why are we here? Let's bring the energy back. Let's parking lot right now for a moment. And so allowing for, again, that complexity to be a part that you anticipate, and in real moment, we're all going to handle those things pretty differently probably.
Yeah.
But I'm going to borrow phrases from both of you guys. I'm always doing that. Anytime I teach them or I work with other people in cases, I'm always like, oh, that's a good little phrase. So I tuck some of these away, so it's nice continuing that for ourselves. Sometimes the learners give us grief. They'll say something and be like, ooh, repeat that, please. So I can use that later. It just broadens your arsenal of tools that you can pull out. So.
Definitely. I think lead with vulnerability. Another just kind of concrete tool is if they're really not getting it, be like, look, I've been in this, even if you haven't actually been in this position, right? It's okay. I've made a similar, I made a similar assumption once when I was under stress, and this is how I dealt with it. So I think if you bring it back to yourself as well, and to sort of that patient care aspect, you make it a lot less, you make that person feel a lot less defensive, and they might actually be more open to listening to you. But yeah, it's definitely one of the hardest type of learners to deal with, but sometimes you're gonna figure out that they're upset because they just don't get it. The very first time I ran my workshop, I was still a SIM fellow, and there was an attending who was like, he said the same thing. Well, I don't understand. If impact is more important than intent, then anyone who's very sensitive is going to tell me that I have I'm committing a microaggression. And all the other learners were all women of color, and they just like tore him apart. And I had to be like, all right, hold on one second. What I'm understanding is that you're not clear as to when to figure out whether you're a microaggressor or not. He's like, yeah, I feel like I don't understand the concept. So it wasn't like he was being racist or difficult. He genuinely could not understand, and he needed someone to coach him through the whole thing. And then by the end, he was like, okay, now I guess I understand. And I had to approach it differently and say, well, how would you respond to someone who's just hurt by something you said? Forget about the microaggression aspect of it. Like, what is a normal professional response to someone saying, hey, you said this and it really hurt my feelings? Are you gonna be like, well, no, I wasn't trying to. No, like the ideal thing is to say, I'm really sorry that this is how I acted. And please help me understand how what the impact was so I can do better. That's it. So try to kind of figure out like where their frame of mind is, but I agree with Ernesto, you have to calm yourself down first, because you can get that internal activation as a debriefer is so real. There have been times where I've had to pull myself back, be like, I am getting upset with this learner, and I need to like have another facilitator take over for a minute while I settle myself, or I need to just focus on a different learner for a minute and come back. And then your last but not the least is this person, like your engaged ally, storyteller, someone's just taking up all the airtime and no one else has time to speak. Affirm their contributions. Thank you for sharing that. I'd love to hear from this side of the table. I'd love to hear from this person. Or like, Denise, what do you think is going on? If they're going through a whole story that's long-winded, yeah, no, I definitely, thank you for sharing that experience. What was a concrete takeaway that you had from that story that would be helpful for everybody to hear? If they're like kind of talking about theory and behavior change models, thank you for sharing your expertise with us. How would this look in a real-time patient interaction, right? So just you got to try to redirect them a little bit. So just to summarize, observe and assess their participation level, how activated they are, right? This may take some time. You might either figure that out sort of beforehand. This might be a resident or an attending that you know is going to be a certain way. And then identify that pattern, right? Are they activated and calm? Are they activated and just like participating very heavily? Are they kind of taking a step back? And then select a strategy to address that specific pattern. And there's a prompt bank here that you can use. This is just some examples of language that you can use for every single facilitation goal. So if you have a activated, upset learner who's defensive, your facilitation goal is to re-anchor to patient care and safety, then one of the examples you can use are like, well, how might this affect patient safety, for example? These are just examples of language. We're gonna have you, we're gonna break into small groups now and have you practice some of these things, but you'll come up with your own language that rings true to you. And what makes sense for you for each of these strategies. I'm gonna hand it off to Will. Yeah.
All right, we're almost done. And we'll have a little short break. This last part was co-created with our colleague, Dr. Chari, who's not here, but she definitely helped with this. And really, this last step of the cycle is the evaluation and implementation of our simulation. And the way that we decided to make this as concrete as possible is using the RE-AIM framework, which is kind of suited in the implementation science field. And so many of us really design really thoughtful simulation programs. But if we're honest, a lot of times we define success as, did the session go well? Did the learners like it? Did we get really good evaluations? But implementation science asks a different question. It asks, did this intervention actually did it actually happen in the way it was supposed to happen in the context of like real world? And also, is it sustainable and does it last? So here we're trying to make this key shift of like, does this, not just does it work, but who is it reaching? Who's adopting it? Is it being delivered as intended? How long does it last? Is it actually changing behaviors that we want it to change? And so to make it very concrete for simulation, specifically for equity-focused simulation, you can focus on creating like a bias mitigation sim, for example, or a scenario about structural racism, or a case that's discusses like social risk factors. Instead of, to take it to the next level, we're going to be asking specifically is how is this curriculum getting embedded into a broader system of curriculum? Are we making sure it's reaching all the learners that we want it to reach? Is it changing practice? Is it changing behavior? And does it persist beyond just an enthusiastic champion, which I think a lot of people can relate to, especially in our institutions. And so one of the ways that we could use it, how we could do this and answer these questions is using the REAIM framework. And I'm not sure how familiar people are with the implementation science literature, but it's something that I think I've heard a lot more about recently, and I've read a little bit more about it. And really, I think fits naturally into simulation design. And so REAIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. And each of these are kind of asking a core question, right? So for Reach, who is it affecting, whether we're talking about learners or patients, who's participating? For effectiveness is what's the impact? And specifically in a simulation, it can specifically look like, are learners demonstrating this behavior or skill that you're trying to teach? Adoption is who's taking it up. Specifically, as it pertains to simulation, it's which faculty are like volunteering, which faculty are facilitating, which sites are incorporating it, who isn't incorporating it, who's not being involved. Implementation is how well it's delivered. And so this is kind of like, is it being delivered as designed? And in simulation, it specifically means is the debrief equity-centered, which components are being skipped during implementation, for example. And then maintenance, I think this is one of the more difficult ones, is it being sustained over time? And so one kind of question you can ask yourself as it pertains to simulation science is like, is this just like a one-time thing that you do? Are you doing it next year? Is it being institutionalized? Are you getting buy-in from your department or your institution to continue to do this work? Now, where I want to take it one step further here is applying a JEDI lens to the REAIM framework. And so there's a couple other specific questions that we can ask ourselves here for REACH. And so the question is all learners required to take this course or this simulation? And a lot of times I think, at least based on my prior example, it's always the learners that are like self-select into these things, right? So applying a JEDI lens to the REACH component is making sure that all learners, are they required to take this? Are we also engaging our part-time or community docs into this, or like our PRN faculty, or and then also asking, are there any groups, marginalized groups that are not participating? For effective, you want to kind of take it to the next level and see if you're actually improving skills across groups. So not just like as a whole blanket, like all residents, thinking about it as different PGY levels. You can look at different social identities as well. And so looking at outcomes by learner identity, for example. For adoption, I think this is very common that we see that oftentimes it's our JEDI champions who are doing this work. And one question you can ask yourself is, are the JEDI champions the only users that are doing this? Is uptake being influenced by power structure, how faculty, residents are being engaged? For implementation, you want to make sure that you're asking that is your equity content being preserved? Are your facilitators trained for psychological safety? And then are there any like agendas or different goals that other people may have as you're implementing this? And then for maintenance, is this person dependent, which I think oftentimes it is? Is it budget? What's the budget? What are the resources? Is this embedded into our existing like residency curriculum, or is it being endorsed? So these are specific lens that you can apply to the REAIM framework as you think about how you are going to be implementing and evaluating your simulation curriculum. So with that, we are going to take a break. I think we'll give ourselves like 10, 15 minutes to kind of take some time. And after that, we're going to be going through this actual toolkit. That way we can begin to apply it. And I think since we're such a small group, I think what we could do is we can just kind of maybe go through all the kind of sections together. Or I don't know, maybe I'll let our participants choose. Do you all want to like go through, like rotate through stations? Should we do it together? I think we have some flexibility here. Any preference? Cool.
Great knowledge in the group.
Yeah, great, perfect, sounds good. So let's go ahead and just take a quick break then. Cool. So maybe, let's just do, 10:50. Yeah, that way that'll give us enough time to go through the toolkit and allow us to wrap up by noon. Yeah, okay, sweet, already.
We've done a lot of like what those small groups would feel like, and so they'll have time for expand on that, but. I think,
Yeah, for sure. Cool.
And the restroom is straight down the hall and on the right if you're in the women's and across the yeah.
And the door's open, so you won't be locked up. Yeah, I was locked out there and I was trying to knock softly. And then I was like,
And then you started banging.
whoa.
You did text me,
No,
but
I text
I
you,
saw
I
it.
text Will,
But
then I
I'm
text
on
the whole
silent.
group, cause I was like, okay, I'm watching the group over there go in and doing everything.
Sorry, I was on silent.
Well, and that's what I figured, I said, boy, everything's just great, so you're all on silent. And then at that point, I was like, let me just bang, 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 bang. Let me in.
All you needed was a window where you can press your face.
There you go. I was trying to like look in the sun, and then this group here was starting their class, and they were looking at me like, wow, she got her face in the oil. Crap. I still got more coffee, but I
it, I just saw it.
As a facilitator, so I think that's a really great idea. And what you said about saving the sim, I wonder if I can, if I start early enough, if I can like go up part-time, 12 days to do something like that.
How many hours do you get for your, like, how many hours is the faculty development?
So we do a quarterly full day, 8 to 5,
wow.
but one is, so it's like, research, we call it back to Friday, research, operations, education. Um, but hypothetically, or theoretically, all of the full-time faculty are required to attend. And they fill all the shifts with PRN,
Yeah.
et cetera, during that time. And I think the real difficulty is the operations are going on their own things that they're trying to accomplish. But I think that really the education fund would be where, like, right now I have a vice chair of education for Friday, that maybe could happen.
I
And I
really,
think that would be the move to even, first of all, I think they did, I need to also have more maturity during this one, so I need to figure out what they actually did.
yeah.
Because I was not at all really, it was theoretically related to our skill center, but because of our situation where it's like, there's no one who has formal simulation training, I have the closest sort of, not even as a chief resident, I ran a sim curriculum, but it was not formally anything, and they do have a sim fellowship, so I got to go down from the sim fellowship education, but I didn't do fellowship. And then our sim director has a med ed fellowship, but not a sim fellowship. When I got to San Antonio 5 years ago, sim was in a conference room with a mannequin in the corner doing oral board stealth discussion with the mannequin sitting in the corner. So we have made great strides, but that is where we started for what they were doing. And so I feel like it improved substantially, but we have no way, like ancillary support, there's like no way any time in the probably next 5 years we could ever afford having like a sim tech to run the case so that the faculty can focus on debriefing. And our faculty, we're trying to be better about like familiarizing them with the equipment and things like that, but it's complicated. And then of course if something goes wrong, fine, but there's always intuitive, it's so hard to use. So if you have someone who knows how to use it to actually do that, so the faculty can focus on what is happening in the case, I think that is the dream.
Yeah.
What about like, do you like a research system that's sort of as your RAs?
I don't know.
I wonder if there's a way to reimburse them or, a way to get them to borrow. It's not, yeah, I think we used to have the rotating lessons, like for lessons that did the similar thing, we would have them do that stuff. And then they have to, we would have them write the case so that we can get feedback on it. But generally was for your residents that want to do that.
Yeah, well, I think we don't have enough residents who want to do academics, let alone sim. We'll have like someone who's very interested every couple of years, or even someone who has, for example, we had someone who's very interested in women's health, and so she wrote a sim in that category, although she had no interest in academics, but she felt strongly about topics, so we've had things like that happen. But yeah.
Tell you what, since we've already started.
I know, I just started.
Let's go ahead and get it.
Yeah.
So,
Let's run it.
thank you. So, both of you, in the packet you have, or your, handbook packet, remember, I, was talking about topic selection and this framework, and so, that's the most important thing, is figuring what is my gonna do. So, let's kind of start, and I think, I tried to get you already in this mind frame to start thinking about, clinical condition, or health disparity, thank you. That, you're aware of and that possibly has some local, context for your area. I think you've at least identified part of it, but what about the clinical condition?
I think that the biggest case in which our Western speaking patients are typically in the pediatric PDs, so I would probably do more straightforward pediatric presentation of but something that, because it's frequently like ERI, so maybe a little bit more than that, but something that's fairly straightforward medically, but requires trailing bronchiolitis or something like that we see a lot clinically, that there's substantial communication involved, I think, with like your child being to admit it, this is probably not oxygen, this is what's happening right now. Why are we holding everything down section? Like something that we see a lot. Your ed shouldn't be medically a huge lift, but then to think about.
And so, I guess you can jot it down, I'll let you jot that down. So, on your clinical condition, you're saying maybe remember, you can also double check. And you were just speaking, you told me you have operations team, right, research team. So you can sort of check with them too, that things that will bring them to the operations team. Are they working on this in your hospital or any other specific thing or research team? Is there something for information or, some research that's going on there? And I think you, just because she had started talking and she came in earlier, so
I'll just.
you talked about language, so you have a population so I'll let you kind of keep going around on targets and behaviors and then we'll kind of learn more about so you will aware of these specific conditions. Oh, sorry. High numbers that you see a lot in your department, or any specific condition that you guys are focusing on from a GI perspective, maybe stroke times that are too high or anything like that?
On the clinical condition specifically, not necessarily, but I know there's been a more GI emphasis on like safe discharges, and like limiting bounce backs and like more feedback from discharges, from patient surveys and things like that. But I'm wondering if something like epigastric pain, like a gastroenteritis, could be, because it's something we see very commonly, could be a good case to do with like a limited English population. But it's what I'm thinking about right now. Like kind of focusing on the discharge piece of it, safe discharge piece of it, and the communication there.
What about in your area?
To interrupt, I think it was 2 more minutes.
Oh, okay, thank you. No, I didn't know I'd started, but now I've started, gotcha. What about, is there any specific, disparity in your area or your zip code that you know about? Because what is your, I know definitely San Antonio, the language, what about?
Our primary non-English language is Spanish, followed by Portuguese. There's a large Portuguese population, large Cape Verde population that speaks Portuguese. It's probably our largest two.
Okay.
I would say disparities everywhere.
Yeah, yeah.
It's just absolutely everywhere, unfortunately.
Or what do you see, or what do you, anecdotally, what do you see going on more in your, what do you think is using health solution?
I think diagnosis of diabetes from the emergency department is something we talk about a lot, and folks have been working on kind of connecting our patients to free clinics, primary care. Like lack of primary care access is also a huge, huge issue out there, but specifically as far as for the treatment population. Yeah, what kind of it? Right now, I'm kind of aligning with things that are going on right now.
Okay.
Is like, yeah, it's like very basic.
I think that's awesome.
Mhm.
The case to go with like, sorry.
No, no, no.
It's easy, right? That's
Mhm.
right from the other
Yeah.
side.
Yep.
And then focusing on that strength. And this is actually, I guess, in the literature on huge gap.
Huge gap, yeah.
Interpreters in the end. and
Yes,
so,
yes, yes.
We'll get what we need.
It's a
at the
research
beginning.
interest of mine, and
Yeah.
I'm sort of working on a chart review for that. But,
It's hard to transition.
Yep.
yeah.
We're being that, because the hospital will very much care about saving money in thousands.
Yep, that's what you just did.
Yeah, so I mean, I feel like there's a lot of actual transition outcomes in using that. That's really.
So we got two, you can fill your matrix out, I think you got it there. Now, what about you, sorry?
So that's okay, what was the question?
So what we're doing, we're starting at the beginning and we're going over case selection and topic framework. And so what we're doing is going through the
Talk about the first one topic.
and we're doing the case design measure. So it's on page one.
There you go. Okay.
And so first sort of just kind of going over these things in our head and to consider and trying to collect and choose a case. And so thinking about at your institution, are there clinical conditions that your institution is very heavily sees? Do you specialize in anything at your institution? And then from quality improvement, are there quality improvement projects going on or significant research projects on intubation or anything like that that you feel that's going on at your institution that would be quite relevant?
I think, I can think of any projects right now that, like, are you asking to think about it or to
Yeah.
share?
Oh, well, you can think about it and share.
Okay. But I think that for us, we have a big Amish population, and then we also have a lot of like refugee, so like a lot of different like source countries.
Okay.
It's not one particular one, but it's like otherwise not extremely diverse. It's like a college town, not extremely diverse, and some of those people are actually biggest populations. But I think like the goal from here was to, it's more like a culture shift. I'm not sure if there's like a specific like problem other than I think in general we struggle with just like having this intergroup develop. It'd be nice to like find an opportunity that like people would connect with and be excited about more than like addressing a specific problem.
Okay. But in order to do the case, like, that way it just doesn't hit, like we talked about, some of the pitfalls of just tokenism and things like that. So when you just sort of take, oh, there's racism, all right, that's a cool topic, let's do it, right? Then that's where it kind of falls through, and so we can, set objectives that are on, based on the competency realm, and then be able to continue to go down there. So, but, sort of in that tune and looking at, health disparities is, I don't know very well, maybe doing a little bit of research on the Amish population, so if there any specific health disparity that's there, and then that might help do it. All right. And my time is up.
Yeah, so I think you have to go to the standardized patient and recruitment.
How long did you say we're doing? 10
I don't know,
minutes?
she is on it though.
Per the request of Dr. Newman.
I was like, wow, she's done it. I didn't even know I started.
That's what Will told me, I promise, it wasn't my
Yeah, that's
idea.
right.
No, we're
Yes.
joking, we're
Yes.
joking. We have to keep us on time,
This is
so.
awesome. So I know you've got that in front of you, the checklist. I also will try to keep mine short because I know from our discussion earlier at the SP piece, it sounds like, I don't know that I think from where you all are starting, I don't know if you have SP programs, or if you have an SP program that you have access to, or yes? Oh, okay. Okay. So let's talk a little bit about that. And any questions from like this side to the content?
I feel like I would have to go to an SP program based on I haven't, I'm usually not the one who makes so I would have to find out if they have anything more than I've experienced, but it has typically been, I mean, I think it's from the school.
Yeah, I'm sorry.
It's their SP program that we sometimes,
Okay.
and I think cost is an issue. But I feel like, especially if I am doing a
Okay.
language barrier focused SAEM, and excluding Spanish, then I would need to, which I think would then be much more helpful also. And I know that we have a question interpreter, and I think I would have to communicate. I would find someone within the refugee health sphere who is involved potentially in something be able to.
I think that one who might be surprised, so we actually had my program manager do a survey of our SPs of the native languages they speak. So the fact this is what you might express on the comment. And I like your thinking outside the box. When we did a interpersonal, well, it wasn't interpersonal, it was specifically adaptation. But in language, we actually did tap into interpersonal services, but then really using some sort of checklist because they're not like, typically an SP, and also they are in a positive space in parallel adjacent space, and so being really deliberate in that. One, being clear what you're asking of them, two, being clear in the training, particularly when you're using Somali, and even just getting the Somali someone to be like, hey, would you be willing to play this mom, and the simulation was a little bit of adaptation, and they had no idea like what that could entail, right? And so particularly in this Asian population, honestly, like, why do we do it? And I was like, okay, so just conversing in Somali. And it was actually really powerful to have, because the other suggestion I have for the things is you can use when you have interpreter lines and just tell them you're doing a simulation, but what was really powerful in that simulation was that the person that played our SP or played the role was our SP, also spoke both languages. So they actually were able to tell us about some of the gaps from the interpreter line that we had and how that impacted, hugely impacted the communication, right? That we don't realize. I speak Spanish, and so but I always use an interpreter so I don't speak well enough. But I can always tell them that the way they're translating, I'm like, oh, they are just not understanding. But any other language I don't speak, I'm missing all of those cues. So that simulation was so powerful. There was these huge aha moments. So I think being deliberate about what that speak typically, what context did they need to have.
Is the same interpreter line that you use in the hospital.
Yeah, so we built in one of our video, whatever one we had there, this is
It's a free-way to sit, like, and very high fidelity.
We use it in our Insight 2 program as well. And discovered that like half the time our iPads are so hard to find, or they're on the battery, or
My seal breaks me, I have to use them all the time, like.
yeah. I remember. So the other is though, so if you can't see, let's take the video one, then you do the phone. We have a phone one all the time. Just on this simulation. I mean, like one time it was so bad we used the hang up call again method because I was like, and it's simple. You can tell, right? Now I feel how you get it from me not having any idea how just how we continue to interpret what we're seeing. So, okay, cool. So this part, I mean, I guess I would, so I created this checklist. I think this is a little bit different than I think what I had put together. It's a little bit more condensed, but I do think it's important to be really deliberate about the things you're asking and you're working through. So just in that recruitment and casting piece, the biggest goal is that you're ensuring authentic, which is kind of what we talked about earlier, right? Ensuring authentic representation while still maintaining the principle of do no harm. And the do no harm, I know here, this is focused on SPs, so it's do no harm to the SPs, but it's do no harm to anybody, right? Like that's our goal in that room, and thinking about all the different roles that are represented and all the intersectional identities of all those roles, and how that comes to play. And so, and it ties to everything Jackie said as well, right? Just having a very clear, defining what your topic is and what's most relevant. So even in the recruitment process, are there certain what is the objective of the scenario, and so what identities are you recruiting for? I will say, actually, I was just in current context, we've had to pivot, just like we've had to formerly known as titles, we've had to pivot in our recruitment, which can be really challenging because you can't name identities, so we had to change how we were recruiting for our, specifically our transgender education simulation, because we couldn't explicitly put that in our flyers. So we just used images that were relatively clear, and then being upfront with people, and then like Jackie had said, like on the community, I would attend shows specifically looking for the smaller theaters. I was in Minnesota before, so it was much harder than I think out there now to recruit. But we recruited across the country, like I did some in Boston, and really looking at some of the spaces that maybe people aren't, as we talked about. You should. And then the other option there is considering telesimulation. So if you can't find something, rather than either misrepresenting it or trying to get it just as close or missing that expertise, consider is there a way to pull in some national colleagues and maybe have us do some smarties with you virtually. I've actually seen that done really well. I know post-COVID, some of the teams done really, really well. I think they got a lot of experience doing simulations. So this checklist, so this first piece, just being really clear about defining, and then what are the identities of the SPs that you're recruiting, congruent with the role, avoiding tokenism, we talked a lot about that, disclosing content up front, and including community partners or your actors as co-creators. And this is huge. I mean, very deliberate about doing this. Whether that is, and you can kind of decide where in that process potentially it is, and depends how heavy this scenario might be on the medical side of things versus communication piece and how you design the scenario. But that co-creation, I think, is really important. And it gives them, a number of times the SPs you're recruiting are doing this for a variety of reasons where they are so passionate. So I've had SPs who have done, they're like, yeah, we've done, I've had a lot of SPs in Minnesota, we had SPs that tell us, hey, we've done this work for law enforcement, but we would come in and play a role and never got to give any feedback. And so like crazy things will happen in the sim, I'm playing this role that actually I live in my real life, but then I don't get to give feedback or I don't get to respond to that. So I think the co-creation goes from front end to back end, right? Through that debriefing, a lot of having the space for them to give feedback to learners or some form of closing the loop for them is important. Informed consent, I think that's important. And I use that terminology because we're familiar with that terminology in the medical space, but thinking about what does that mean in this space when you're asking someone to bring parts of themselves, right? It's different than acting, coming in and playing for a medical scenario often doesn't intersect who you are in that way. Their prior experience in scenarios. I mean, this can be really challenging to get at. Like, I've had an SP where we interviewed, it went okay, and then we were doing the training, and I was like, oh, we kind of discovered mid-sim, and I was like, I think he actually was bipolar, and he had hit off his, I mean, there was a number of things, and we were doing a mental health sim, right? And so, it was very hard, but
Too realistic.
yeah, it was like, this isn't important. But it was really challenging. But I think trying to figure out how can you, in that audition or interview process, even if it's through your SP program, when you're explicit about what are my objectives and what is the case study on me, it helps to get at what are your lived experiences, or your just in general experiences. So you're able to think through how might that intersect in your scenario and your simulation. and that ties to confirming their comfort and portraying specific identities. And I think this goes both ways. So right now I'm really focused on portraying identities potentially that intersect with their identities. But I think on the other end, I know we've done this, and I know you've done this, right? Well, where you're having somebody play the aggressor. I don't know if that's the right word, but like the person who's doing discrimination. And I think having some clear guidelines around that is so important, right? We did a whole big project, wrote these cases, had someone play this role where they were the white nurse. That was because we were filming the cases we had been doing, and she played this nurse. And then when she saw the video, she was like, "I'm not comfortable. Like, we just get all this money to film it. Like, yes, would you be comfortable?" And it gets but also it was really important to us that it was clearly labeled. Like, these are folks playing a role. This is not who they're acting. This is simulated. So I think both ends. I think it's really important to make sure you're gauging people's comfort and being in those roles as an SP. And this is an interesting, the document casting decisions and rationale. What was that?
Give you your time.
Oh, my time. I'm on phase 1. So let's get into it. I think the documenting is important because we've been talking a lot about your institution shutting things down. And so I think documenting and tying it to this piece where you're doing case development, like why you're doing this, what's the outcomes, what's the quality pieces, or what's the disparity you're addressing as you're casting. Because again, if you have flyers out there, you're recruiting specific, and you could get in trouble for that these days, unfortunately. So just thinking very deliberately about that. Okay. Next phase, we talked about the training. So this is kind of a list that, and it's really checklist format so that you're really thinking about and just keeping that major goal of that section in mind. And so this, and I can share this, right? The standardized portrayal and prepare SPs for emotionally complex interaction. I think the tool you have in here is this checklist, which is a version of this, but I think this is, I have one that's a little bit more detailed, I'll share. But I think this piece where the standardized portrayal is interesting because sometimes it can be hard to get to depending on what level of, if it's an escalation or what level of emotion they're bringing into the case. And so I think when we think of, and also why we've changed from using standardized participants or standardized patients was the original terminology, simulated participants, right? That encompasses a little broader, and deciding if you need it to be standardized or not. I think that terminology was often used because SPs were traditionally used in OSPs where it needed to be standardized, it was assessment, there were consequences, and in your case that might be the case, right? So just thinking about that deliberately. The practice we talked about preparing the SP for the range of learner responses, including dismissive, defensive, all the ones that we spoke about in the section, having a clear scope, and then the rehearsals. Questions about that, about the training or how you set things up, and stop word, safety. So then the third one is psychological safety, protecting the SP's well-being before, during, and after the simulation. Again, just noting that my portion is focused on SPs, but of course you're trying to protect everybody's well-being in the room and in the simulation during. That's really important. Establishing the race-based norms with the SP, because the SP may not be part of it. Depends how you set things up. I think this piece is important because if they're not part of your pre-brief that you're doing with your learners, then being deliberate about thinking about setting up that same space with your SP before they're coming in. So I've done it different ways. Though the simulation that we did, the SP was not part of that pre-brief because they wanted to enroll once learners were there. So they would come in and enroll, and we wouldn't introduce them at the beginning. But then we did make it a point to, after the sim ended, allow them to introduce themselves with their real name. And so if they aren't part of, so that's important, but if they aren't part of the pre-brief, then making sure somebody's doing that pre-brief, the basic, going over basic assumption, especially if it's not from an SP program, if you're recruiting from the community, you're coming in to be part of the simulation, being really mindful of that piece, because there isn't a structure that already does it, right, if it's not from an SP program, so it's important to have that piece. And then checking in with them between learner groups, especially if there's a high volume of simulation days, and then having some sort of de-rolling process, whether that's, we actually expanded ours. We had, in our green room, we had other modalities they could use to de-roll. We had someone that would be available if they wanted to talk to someone to verbally debrief, but they didn't have to because everybody's different. We also were very deliberate about the identity of the person that was helping them de-roll for those particular sims, because my colleague that I work very closely with and is very passionate and really incredible at this work, but is also a white nurse. And so they're being very mindful of, hey, they just did the simulation, that I hold this identity that they may be associating with some of the trauma they might have re-traumatized in this, and potentially, hopefully not, right, we've set this whole situation up, but also that might not be the person they want to debrief and talk with about some of the things that might come up in the scenario. And so, just be mindful of what is the space we're creating, whether that's virtual or a phone or somebody's there. Create ways to do that.
Good for you.
Right, yeah, and then the last one is phase 4. So we can, and so just, this is, maybe even repetitive, but, again, creating that space of what we post-nation. Awesome. Sorry, I'll share. And just keeping the goals in mind for each case. Yeah. Any election?
Sweet. I'll take a lead on this one. And so I think there's a couple, I think we can break this down into two kind of separate things. I think for the first part, in terms of like this being time for you to really think about what you want this to look like, I think we'll spend some time on that. But some of the other things, such as the equity sensitive design checklist, that's like something that you'll kind of internally do. We'll talk a little bit about this, but just to kind of be thoughtful about, your time here. And so I think for starters, I know you all already selected the topic, and potentially have already identified what type of target behavior you want to do. That's something you'll feel comfortable sharing right now in terms of what your SIM would be potentially targeting.
Yeah, I mentioned clear communication around discharge in an effort to prevent bounce backs, but really just confirming that folks are actually talking to people for medical what the appropriate modality, giving time for teach back or things like that.
We talked about pediatric case because that is the most frequent scenario in which we are seeing patients who need push to, which is but yeah, I think that will probably be something like that.
I think it would work that bronchiolitis, and you might have to use a mannequin for the child, but that would save you a lot of XP, something you only need one XP to play the mother, and then use an interpreter like that. Close communication. I was like, wait! And then do you use close communication as target behavior? Yeah, with an interpreter. Okay.
I think we talked about that. Someone brought up like the stroke example with interpreting.
So it seems like the big thing is going to be around potentially like navigating systems, being able to, I guess, kind of right? It's just kind of like ensuring clear communication as like the target behavior, like whether that be teach back as well as another concrete target behavior. I think is something that you can potentially like focus on is how residents are engaging in teach backs as like the objective for the target behavior as a way to kind of like be more inclusive in terms of like this event's communication scope. I'm sure there are other kind of communication frameworks that you can potentially target, but I think that's one of the, it's very important because this is, as Saru was saying, that you want to make sure that you have a very clear objective, and in having that clear objective and connecting it to a communication framework, it's going to be a lot easier to conceptualize it, learn it, and then also even potentially be able to move it.
So, from a scope perspective, because I think all the travel making is too complex, trying to do too many things at once, and let's say I had a HGTV patient who was female, would it be too much in one SIM to be trying to address cultural sensitivity as well as the communication piece, or is it better to just let's focus on communication and using the interpreter
It's a good question. I think it largely depends on where your learners are in terms of their background and their probably not enough time to like dive into both of those things. But if you're doing much like a two-part sim type of thing, it may be reasonable to kind of integrate it where you like first you know do the interpreter communication skills kind of aspect where you kind of like debrief on that, and then like the second part of the sim then really hits home on the cultural responsiveness of the care. But you know, even then, I think it's still tough. It's still a lot to
Yeah.
And I would say the third thing that you mentioned is who you're facilitating.
Yeah.
I think all three
Yeah.
of those things are too effective, and the third one is who's facilitating. How they navigate multiple things in a smooth way.
And the way you described it, Cindy, I think that would be too much. But what you can always do, you could, sort of like what Will said, do it two different, or he said two different times, or two different, sims. But I would do two separate sims, right?
Yeah.
So that way you can use the same case. With a lot of design, you can use the same people, right? But be able to do that at another time, and that would save a lot of workload and things like that.
I don't necessarily disagree. I actually agree with both of them, but I have also seen it done where it was done together. I actually mentored a project where it was actually exactly that. It was cultural considerations and the language piece. And it actually went really well because they do tie together really well. That's why I thought about facilitation, because it really depends on what is the aspect that you're trying to get at. And I think I agree with both of them that separating gives you more time to dive in, but I also think time is a luxury with a lot of our learners. And so if you have limited amount of time with those learners, I think it is valuable to do something really combining those, but then being really clear about what are the pieces you're going to try to get to in the briefing and what are your objectives, right? Is it like, hey, we're discovering how long it takes to get to the interpreter? Perhaps not, though, right? If that's not your objective, then you're really clear of what is the scope of this simulation that does bring in the language barrier, because it adds to the confusion about the cultural considerations that you take into account. I'm presuming some of the things that might come up is like, she doesn't want a male doctor, right? Like, there's going to be a number of things, I imagine, in that scenario, and I do think you can combine it, but they would have to be very deliberate. And what am I trying to get at? And use facilitating to do so you can get at those things.
I think sometimes also your case can be one thing, and your debrief can be that plus.
Yeah.
Right? And
That's
so you
true.
could,
That's important.
and especially if you're still, if this is very new, right? Debriefing some of these more advanced edge DEI, JEDI topics are a little bit harder, but discussing them are not, especially if it's very relevant to your work that you're doing. And so you could do the language piece and then go, hey, let's talk about some of these cultural, like I've experienced X and Y and Z, and how do you navigate that? So that's a way of like, yes, anding the situation.
It's a really good way to do that.
One more question that came up while we were talking. I know we talk about like the size of in a communication-based sim situation. I'm mostly focusing on the communication with the interpreter. Do you typically ask one, let's say, resident to be the communicator? Like how, from a logistics standpoint, is it one person communicating, or other people standing and watching, or like?
I have an idea for you. If you're able to do like a two-parter sim, what you can do is have like half of your learners participate in the first part, which is your language, your interpreter one, debrief them together, and have the observers kind of also kind of chime in into plus minus delta. And then your second parter can be with the objective of that cultural sensitivity, and then you switch the learners. And that way, everyone is a part of everything, and everyone gets a chance to be engaged.
The way that we operationalize this is we also have a very similar kind of concern because we wanted all the learners to like be able to practice the skills, and like it doesn't make sense for the learners to be there, see the case, and they already have a preview of what the case is going to be, right? So it kind of like reduces the fidelity in that sense. And what we did is we used a kind of go to step 3. We used a fishbowl kind of rotating exercise where we had four or 5 learners, I think it was 4 learners per fishbowl group. so then that way each learner had a chance to like, you know, deal with or not deal with, practice those communication skills, and then the rest of the learners were there to observe, so they can also get some, you know, something from it. And so I think in those cases it's hard to do it, and it requires a lot of resources and time. I think the alternative thing that you can do that I have seen is the case-based vignettes, and like in terms of it being like a video with something that you watch, and then that way, you know, you can show the videos and have each learner a chance to be able to, you know, identify certain communication practices. Again, that one's a little bit less fidelity and may be hard to kind of like get those concrete skills and practice those skills. But I think there's different ways that you do it, and that is, I found a fishbowl exercise to be used.
We put in the fishbowl a little different, where it's a play pause, and that has worked really well, as long as you're having facilitation and scenario with micro difference. So we've done the maximum of 8 people in the kind of fishbowl after. I actually have video of it because I know for me it was all conceptualized. I can show that at a good time, where all the members can participate because you're doing the pause, and then you can rewind. So there's a rewind, right? Where someone goes in, when they get stuck, they pause, and I might go say, do a micro debrief, and what others say in the situation. Somebody, and then somebody gives a suggestion, you say, do you actually try those words, right? Because we talk in debrief all the time. What would I say? It's really hard to actually say it, and so let's get you the same, and then they switch out. And I think that also, for me, it was helpful to that psychological safety, right? So to have 8 people just watching this one person go all the way through the scenario, it's really challenging to do that in person. And so, but we would set those expectations right up front. I mean, all of you, everybody's going to participate. So I think that's another way to fish.
Yeah, so we use rapid cycle delivery practice, which is very similar.
Yeah.
I would say, like all these things, you want to do those techniques in non-JEDI settings, so that your team's familiar, because that rapid cycle delivery practice is odd, right? To get that feedback in real time in front of your peers is very unnatural, because none of us, you know, most of us have typically not had that scenario. And so we've used it in a variety of ways. We tried to do it in our boot camp for our interns, and so from day one as a team, and that's where.
I guess I'll say it was the only place we used it.
Okay.
We just did a lot of pre-briefing,
Yeah.
and prep, a lot of setting expectations, but not to, you're right, probably it's better if they're used to it.
Well,
But we also trained our facilitators were really trained to this specific topic and simulation, because it's really challenging, right? So in front of someone, how do you frame something? You really have to be very adept at using AI, or degree, or different strategies. I didn't do that.
No, that's great. Yeah, I mean, I think that kind of hits the other kind of checklist in terms of like what type of debriefing strategy you want to use. And so like I think that micro debriefing is kind of where you can integrate there. And the other thing to know is that like these, you can select multiple options, right? Multiple debriefing modalities for each simulation, depending on you know the type of sim that you're running. And so it seems like for your case specifically, it seems like potentially doing a little bit of micro debriefing, and then you know at the end we do like structured debrief to kind of get more on the cultural kind of aspects, and then micro debriefing really trying to get more on the communication aspect as a way to try to like potentially hit both aspects, which I think also pertains similar to like you know discharge instruction and discharge communication as well. If you want to integrate some of that in terms of the micro debriefing with the micro debriefing. But yeah, I think we'll probably move on to more.
So we're just roll, baby.
Yeah, that's right. Just go ahead and move to the board.
And this is all iterative, right? And so once you've done your case, coming back and saying, how did it go? You know, certainly getting feedback, but asking yourself, like, did I achieve what I wanted to? And then the next time we do this, would we do it the same way, or what? How can we change it?
Yeah. Well, let's give you guys a little bit of some experiential learning. So we talked a little bit about your different learner types and the different strategies that you use to address them. You do have
the grid over here, I realized that the box of the strategies is not in here. But there's a prompt bank with some examples.
Maybe we can go to the slide.
No, because I had to, remember it was removed and then I uploaded it last night. So it's on the Google Doc, but it's not on this. It's on the slides. It's on the language. We'll pull up the slides over there. So Ernesto and I will each role play. There's 3 of you. Whoever wants to go. Ernesto and I will each role play one little learner prototype, and we'll have you as the facilitator try to debrief that. And then if there is time, we'll do the third one, so all 3 of you can go. But
This slide? Right?
Yeah, that's
perfect.
So we'll give you your strategies, and then you have your example languages over here for each of your strategies. It's totally okay to take some time to look at it. I think it's also, it might be helpful to kind of come up with your own language if you can, but I know that all of us watching you would still. Okay.
Yeah, and with play pause, it's always okay to say pause.
If you're having a hard time,
Come
probably
to
like,
your friends, and then be like, okay, let me try that again, and then we'll resume. So we can demonstrate it in the film.
I'll give you, do you need a minute to just like look at the prompt link, or? Wing it. All right. So let's say that we're doing Priyanka's case on bronchiolitis, right, with the peak bronchiolitis, and say your case is around, say that learner had a hard time kind of buying into the idea, even that they're not using the interpreter efficiently.
Like they didn't.
The movie during, so say that I'm the learner and you're the facilitator. Say that during the case that I have a hard time kind of saying that, accepting that like it might not be the most, that I'm not efficiently using the computer, or I'm not using it regularly, or that I feel like I'm just going through concise things with the big deal. Okay. So whenever you're ready. Who wants to be the facilitator, by the way? I won't bite. All right. Denise. All right. Okay. I'm gonna. Yeah. Sorry. I think that there's just a lot of pressure put on us to see all these patients per hour, and then there's all this focus on our RVUs, and then now I have to take the time to use the interpreter, and I don't really see what's wrong with me just like quickly summarizing what happened and telling them to come back if there's an emergency. I mean, there's like no time. It takes so long for the interpreter to get on the phone. This is just, I don't know why I have to do a wholesome session about it.
Tell me more about some of the frustration that I'm hearing about when you're discussing with patients that
I mean, it's just, I feel like I'm like constantly stressing to see patients, and then like I'm standing there on the phone waiting for this Pashtun interpreter, and then there's like 10 people who are waiting to be seen, and they're screaming at me, and there's the homeless guy that's like covered in poop right next door yelling at me to get him a sandwich, and I have to get this interpreter on the phone, and like it's just exhausting, and I feel like this is just another thing of like, oh, you can do better, where it's the system's problem, it's not my problem.
I want to separate out a little bit, because I want to create some space for the topic. So that we can forget about the other things that are kind of important. You think of maybe a patient experience where you were not at all under those kind of constraints. What do you feel that are things that could be helpful to keep you along?
I mean, if there's no time constraints, I agree. Like, if there's no time constraints, I feel like it would be really nice to be able to spend some time on the phone and explain to the patient what's going on. What would be helpful is if the interpreter, like, if I have to wait a long time for the interpreter, if I, like, was able to, if I just had to have a little bit more time to talk to the patient. Yeah, I think that would be a little bit. I guess I could try to take that time even when there is no time. I mean, it's like whatever. If you see a fewer patients, it's okay. I think bounce back.
things that might help you get feedback from the patient about how effective it may be, or things that might help you buy time in the second patient when you anticipate that it's being an occur.
What would have been by time? I mean, I guess I could always tell the other attending that, hey, I'm gonna be on the phone for a couple minutes. I don't know, I think it's just hard to kind of move the time constraint, but I get what you're trying to teach.
Debriefing. I think it's gone really well, and I think it's a little, you know.
I wasn't thinking for the problem.
No, you're
Sorry.
good. You're showing your expertise. And I think one of the things that I was going to call attention to is it almost seems like it's one-on-one, but if you had a group, right, what are maybe some ways that you could do some of what you're already doing, right? Because what were you doing? You were normalizing, you were validating, you were bringing her back, not just to the case, but to like back to the emergency department. And so those are all, these are the techniques here, right? And so you're naturally doing that already. Amazing. And so that's, you know, kind of just saying, because we have this unnatural kind of, Sim's already unnatural, even more in this setting, but I would say, you know, asking the group, hey, has anyone encountered this in the department, right? Great, how did you deal with that? Who else has been frustrated, right? So now we're taking that person who maybe didn't buy in, or maybe that's our interpretation, right? And we're bringing them into the fold and saying, okay, well, this is exactly what I wanted to say this, you know, because, you know, maybe we've gotten feedback from patients, or you know, we've noticed that we have higher bounce backs, and so, you know, how can this help us prevent our volumes the next day, right? And so if we were all doing it, we had 4 or 5 less patients come back in because something was missed, and so I feel like.
Yeah, it's like get your learners to engage with each other. I think that you did a great job actually with the, if you remove the time constraints, right? Like, how would you conduct this? That was a great question. I think you followed it up with a lot of very specific questions that I didn't really know how to answer. So I think that before you lead into more questions, kind of try to like bring them down. Or just be clear about like what you want to get out of them, because I think some of the questions to me felt a little bit like read my mind. So I think you just have to, like, well, do you think that, what do you think you'd be willing to sacrifice in return for spending some time on the phone? Do you think that's even possible? And then you have the group to, that's just my like personal like specific little feedback for.
Time queen, do you think we have time to do one more?
Yeah.
Yeah.
We got 5 minutes for one.
All right. Ernesto is going to be your SPE this time.
Your standard night participant. Yeah. And we'll do the same scenario if we want. And so, but I'll just be a different learner. I don't know. I guess I just do both sides. I don't know.
What are the 2 sides of your speech?
You know, I think it can be really hard to use interpreters, and it certainly creates increased cognitive load and just kind of can take you away from other tasks. But I also see that it's really important.
In your mind, you think it's really important that you just like for you reconcile like how the students do address conflict is
Yeah, I'm glad we did it, but feeling good.
So he's kind of low, yeah, he's like low participation and he's calm. He's not really very activated. So I think that, you basically tried to be curious and you asked and you kind of just to shut down. So I think that what you might need to do is either do some like structured turn taking. So if your other learners, Denise, Priyanka, how about any of you? Like, how do you? What are your thoughts on this? And you can come back to him and say, Ernesto, based on like, do you agree with what Denise said? Do you agree with what Priyanka said? Or how? Do you have any personal experiences with this situation? I think kind of getting them to talk about themselves is like a good way to. Yeah. Like, when's the last time you had to use an interpreter? Do you remember? Do you recall what that? Do you recall any specific frustrations that came up with it, or what about a time that it went really, really well? What were the factors that made it go really well? So you have to get like really specific questions. You can time it. Yeah, you can time back in.
So can you tell me about a time that you feel like this is happening all the time?
Yeah, I mean, I think especially with our, I remember the first time I used the video interpreter with one of our like ASL patients. They were super excited because typically they had to wait so long to get an actual interpreter in house, and they were just like, oh my gosh, like, wow, like I don't have to wait forever to be seen. So yeah, I mean, again, I guess my frustration is, as someone whose English is their second language, I've had to interpret a lot for my family members, and I feel like it's brought up a lot of like negative emotions about how, healthcare providers sort of, I was a 12-year-old and they're like, hey, translate for, so it's just, I think I also it's brought up a lot of sort of my own experiences, and so that's why I've been not as much.
Sounds like this has been like pretty triggering for like past experiences that you've had, and brings up some negative feelings, but you've also seen times which was rewarding for some patients.
Yeah, I think it's just been a lot, so I just didn't feel like sharing too much because of that.
I can understand that.
I think it's fair. I think so. We can pause for a second. I think you got him to go from calm to a little bit activated, but positively, I'd say because he was more comfortable being vulnerable with you. And I think once they tell you that they're feeling a little triggered, it's okay to just like thank them for sharing, and then just move on to the next learner. But you got him to like open up a little bit, which is. And you can also tie back their experience to the greater learning objective and say, well, I agree, and I think that's exactly why we want to make sure that everyone's using an interpreter, because it's not okay for like kids to be translating for their parents. And sometimes a family member just wants to continue for and know an interpreter. And so you can make sure that his experience lands for everybody.
And Chelsea and I know each other well, so I think it highlighted also like how when you have some of your faculty be the embedded like SPs, it creates a different dynamic, and kind of even if you don't use a standardized or simulated patient, but can even bring someone out to your department. It can be helpful so that there's not that like, oh gosh, like I know this person, and so anyways. So that was a natural thing where I was like, I did bring last class.
Our table.
One more section.
If we have 10 minutes, don't worry, I'm a pro at like bringing it in on time. So,
They're union.
are you okay starting with going over some of the implementation evaluation stuff? Remember the AIM framework? The R stands for reach, the E for effectiveness, A for adoption, I for implementation, M for maintenance. Yeah, should be on the second to last page. So if you turn it to the other side, that will get you there. So as you are looking at this, you want to think about like, who are you trying to reach? So remember you were talking about having maybe faculty meeting, and you would think about like, how would I maximize? I was going to throw a suggestion out, like, see if your chair would let you present maybe earlier today, so not the the last one where people are like, oh, I'm so sorry, I gotta pick up my kids at 5 o'clock, or whatever. Maybe like right after lunch, when people are sort of energized, might be more willing, or maybe right before lunch, yeah.
That's when they're hangry.
But maybe not like the last on the agenda, because we know us, regardless of what it is, unless it's the chair, him or herself presenting, people will sneak out by the last thing. But, and then, again, so thinking about your case of the, maybe using the Pashtun interpreter, maybe looking at a sick kid with bronchiolitis. Who would you be aiming for?
For the learners of that case, I mean, I think we largely.
You can be the best team, you can play the better game.
Are you aiming for a particular group, or were you hoping to get sort of everyone? Were you thinking like interns versus seniors, or were you?
I think probably everyone can benefit from it.
Yeah.
So the senior residents will have had more experience using the interpreter abilities and going through this process. Evaluating, take a second to evaluate how well you do it. Probably all of the residents.
Do you have a time frame or like a scenario which would get you the most?
Probably do it during one of our didactic sim days, so we can catch everyone who's not on service.
And how would you sort of measure it, or what's some ways you think you might be able to see if it's effective?
I think it's not hard. Pre-post service, I guess, but I know that's not the best thing. And I don't know if there is a really objective way to see, I don't know, if there's some sort of log that how often the interpreter team or something like that that I can look into.
Yeah, that might be a good way to do that, answer log and
Like
see what proportion of patients are.
getting an interpreter assigned to their account.
You can do that with your if you we don't use Epic, but if you like with the EMR, you can do a search and like interpreters. We did that with our very crappy EMR.
But I definitely think Epic.
Epic definitely. To get your registration staff to put in the preferred language and then how many times like the interpreters have ordered.
So it's just like I have that you grab from the corner and like.
Yeah.
When you got that, yeah, did they ask for it? Yeah.
They
You
don't
don't
ask.
have any information when you.
And on your chart, do you say?
Technically in the note, there's a section where
I was
you can
gonna
put
say.
it. I just don't know how consistently people fill it out.
You can use your ask your IT people to try and collect that data and see if there's routine.
Because you can probably do it too, it's like a two-level way where you see, yes, an interpreter was used, and one, you know, like, it was used, and then the second part would be like, what's their ID or their name.
Yeah. Because ours is like, yes, and then it has categories of like in-person, patient decline, and then it has like the video interpreter or the phone interpreter, and then it has the language and what was discussed, and it's a history taking case. Like I think it's like a little templated thing, and I don't think it has anything specific.
But you could even see if you can pull the registration asking what the preferred language is, and even see how many times it's not documented at all, because I think you're saying it's not consistent, and people don't consistently fill out that phrase or whatever. And then you're just looking to see, hey, this number of patients said this was their preferred language, there's no documentation, we don't know if this was their preferred language.
Yeah.
Or the Joint Commission name.
Yeah.
Our place, our interpreters always ask for the patient number, so we can track it backdoor. But definitely if they hit yes, excuse me, yes, and you have to click stuff, maybe at the very least you can see how many yes, you know, which charts have yes.
As an initial screen.
Yeah. What about adoption? I guess that sort of falls in line with effective, but what adoption of the course, so like maybe how many, if you're aiming for all the residents, you know, how would you record maybe how many of them did it?
How many of them did the course?
I think, yeah. Yeah.
So we would know who took it. I guess it would be who among who took it and changed their behavior.
Yeah. And so maybe definitely tracking pre and post. And we are pushing more and more to do QR codes because everyone lives and dies by their phone. But it also goes straight to whatever survey program will record this stuff, and then you can immediately sort of compare the pre and post data. And if you really want to push, you can do maybe a 6-month where you do a similar SIM, but change a few of the main things, and then sort of do another post.
The other thing for adoption too is like specifically you're thinking about like language, not getting buy-in from like the language services department as well. This is something that we can potentially include as like a onboarding kind of like training as you become a new employee. This is our workflow and like having them adopt it as well as could be like another potential like collaborative metric that you can have on.
Or resident orientation, do it early. And then what about implementation? Was the training delivered as intended? Yeah, and checking sort of the fidelity or the standardization. And that's part of what I've heard today, right? Like, you're the one person on your own. How do you build something that and maintain that fidelity? And then also tracking like how many facilitators, how much project time, how much evaluation time.
Timer.
Timer.
Union workers that keep coming behind and take our roles.
And then lastly, would be maintenance. So maybe you don't do all the residents, maybe you start this year with the fresh. It's May, so maybe you get yourself together for June, July for the new cohort. And then how does it work in 6 months? And then how does it work next year? 6 months, and then year after 6 months. So you have to think about the options. Maybe you do want all 3 classes, all 4 classes, and then you maximize your info, and then next year start with the interns.
Thank you all. Appreciate you all for being here. Yeah, I think for kind of next steps, you have this, but also, you know, I want to make sure that you all feel comfortable reaching out to any of us. I realized that we didn't put a slide with our information.
It's actually in the SAEM.
Oh,
yeah.
yes.
Yeah, so.
You can put the resource link too, we could add that.
Yeah.
Well, if any of you are in New York City.
So please.
Oh yeah, and then before you go, you can do a survey just for like feedback and, you know.
Pays the bills.
Yes.
Well, you had one middle survey. Did you want me to put that on the screen?
No, it's all right.
Okay,
Yeah.
sure.
Yeah.
Okay.
Yeah. Cool. Well, hey, thanks y'all. Appreciate it.
Yeah, thank you all for being dynamic participants.
So wish you all the best with designing these things at your shop. I know there's some challenges, but it's okay to start slow, start small, and then kind of slowly gather information out. Get your bosses to buy in.
Yeah.
And reach out to us.
Yes.
Let's take a picture, I guess without Ala.
We'll have to Photoshop
Let's take a picture. Someone's willing to snap one of those.
Does your camera have like a type of
Yeah,
my